Morning all, and welcome to the second day of our annual PHONZ conference. I'll just open with karakia and then hand over to Chris. Me karakia tātou, whakarongo I au rongo, ke mā tā te rapu mātu hauora, papa o Aotearoa, te manane, ki te ronga, teki whawha, te rawa, te whawha nuku, whawha rangi, e taki mai I au kahu o ngā raki, kia turu, kia whakamau, kia tina. Tina. Hui e, tai ki. Ka pai. Over to you, Chris.
Thanks, guys. Morning, everyone, and welcome to day 2 of the PHONZ conference. My name's Chris Skelly. I'm an analytical program manager with the United Kingdom's Department of Health and Social Care, and I'm chairing this session today. We've got a Mentimeter. I don't know if they're going to put the slide up, but it'll flash it up at various points. And the Mentimeter has questions for us that we'll review the answers to at the discussion session at the end of this section at 10:30 New Zealand time anyway. All right. So first up this morning, Dr. Esther Hamblion. She's currently she currently heads up the Public Health Intelligence Unit for the WHO Health Emergencies Program in Geneva. And with her previous roles in the WHO Regional Office for Africa and the Country Office for Liberia, she'll be telling us about the role of their intelligence activities in enhancing global health security. So good morning, Dr. Hamblion.
I will give her Esther's apologies, Chris. She's not actually joining us this morning. She sent us a pre-recorded presentation, which I will now load for us. Fair warning, everyone, this video is a bit faint on the audio front, so I promise I've cranked it up as loud as I possibly can, but you may need to turn up your own speakers if it's too quiet for you.
Good morning, everybody, and thank you very much to the conference organisers, to Professor Barry and colleagues for the invitation to speak today. My name's Dr. Esther Hamblion. I'm an epidemiologist at the World Health Organization and lead our operational public health intelligence activities within our emergency response program. Firstly, I'm really sorry that I am not there in person today or able to present live due to the time difference, but it really is a pleasure to present to you on the role of WHO's public health intelligence activities in enhancing global health security. Now, the link between public health and security is inscribed in WHO's constitution, which was formed more than 75 years ago now. The health of all people is fundamental to the attainment of peace and security and is dependent on the fullest cooperation of individuals and states. This mandate is then reiterated and expanded upon through key World Health Assembly resolutions. The World Health Organization, we have been undertaking global disease surveillance for many decades now. However, it was the 2005 International Health Regulations which provided the overarching legal framework which aimed to ensure maximum public health security while minimizing interference with international transport and trade. It defines countries' rights and obligations in handling public health events and emergencies that have the potential to cross borders. The International Health Regulations also establish the legal mandate for both the 194 member states of the WHO to notify events that may constitute a public health emergency of international concern, but also for WHO to undertake surveillance activities to collect information regarding events and assess their potential to cause international disease spread and possible interference with international traffic and trade. It also gave us as WHO the authority to access and use non-governmental sources of information and then to obtain verification from member states on this. It also gave us the mandate to alert other member states and the public to potential health risks. It also expanded its scope from previous versions of the international health regulations from a focus on infectious diseases to using an all hazards approach, so including, for example, events that are chemical, biological, radionuclear in origin, or food safety events, or even large-scale antimicrobial resistance events, for example. Public health events are impacting individuals and communities on a daily basis in countries across the globe. As part of ensuring global health security, countries report to WHO events that may constitute a public health emergency of international concern. On the right-hand side, you can see that since 2009, nearly 5,000 events were assessed by member states to have the potential to be a public health emergency of international concern. This is around 300 to 500 per year. Now, over the same time period, on the left-hand side, you can see that 8 public health events were actually declared as public health emergencies of international concern. So this is the highest level that WHO gives to show that an event poses a global threat and requires a coordinated international response. You all know that obviously COVID was a fake or a public health emergency of international concern, but the others include Ebola in West Africa, Zika in the Americas, and currently we have the ongoing Mpox outbreak. And this demonstrates our aim of public health intelligence activities. We aim to detect events early, which enable rapid response activities to be initiated, which averts the additional cases and deaths, as well as the wider impact on health systems and economies, but importantly prevents them from becoming public health emergencies of international concern. So how do we implement this public health intelligence actions at WHO? Well, it is a mix of both the use of technology and essentially personnel. We're a global network of 196 states parties to the international health regulations. We also have 150 country offices, as well as 6 regional offices across the globe, and technical expertise at WHO headquarters. We also have a number of partners, particularly with specialisms in areas such as laboratory or AMR or One Health or CBRN. And this network of people is essential for our intelligence activities and is unique to WHO in enabling the key activity of on-the-ground verification. So as well as having the ability and the relationships to be able to access such a vast network of expertise with speed, this is really key for our early detection. And this early warning system is carried out continuously every day of the year by WHO. Now, for our public health intelligence activities, we follow a standardised set of processes to support the notification and response to public health events which could be potential public health events of international importance, which we've developed over the last decades. They follow a core steps of detection, verification, risk assessment, reporting, and then the action and response. And I'll expand on these a little further as we go through the presentation. But I also wanted to highlight the definition we use for public health intelligence at WHO, and I know this will likely differ across different specialities or across different organisations and agencies, but I just wanted to put this here for you all to see. Now, the schema on the left-hand side of your screen shows our multi-step process for our public health intelligence operations. It looks quite complicated en masse, but essentially it's divided into those 4 key boxes: the detection activities, our verification activities, risk assessment, and our alerting, our reporting, our dissemination activities. On the right-hand side, you can see some of the key statistics from 2024 that we generated. So, for example, the systems we use generated around 150 million pieces of relevant information. This resulted in about 1.2 million raw signals of potential public health threats being scanned by a person, which resulted in around 2,500 signals of relevance, all of which have then been triangulated with other information sources, resulting in around 500 new events last year that were of relevance to WHO. All of this information is then triangulated with other sources and then triaged and assessed by the team before we consider it a potential signal and highlight it for the wider input of the staff who work in the emergencies programme, as well as those working in the field undertaking on-the-ground verification through the member states with our country offices. So, how do we detect events? To detect an event, we have multiple sources of information that feed into WHO. These include indicator-based surveillance data that often feeds into some of our disease-specific programs. We have internal communications as well as partner communications. And this is really key for us to link with others working in the field to hear of potential rumours of public health events. We have a formalised network called GLUES Plus, which is a tripartite, collaboratively sharing information with the World Organization for Animal Health and FAO, the Food and Agriculture Organization, which focuses on detecting health threats and emerging risks at the human-animal ecosystem interface following a One Health approach. We have IHR event notifications, which come from member states or WHO directly, and at the national level, a member state under the IHR assesses all reports of urgent events within 48 hours and then notifies WHO within 24 hours of assessment of that information of any event which may constitute a public health emergency of international concern. And they determine this based on 4 criteria. And if an event matches 2 of these criteria, the event is notified to WHO. Now, these 4 criteria are: is the public health impact of the event serious? Is the event unusual or unexpected for that particular time, for that particular place? Is there any significant risk of international spread? And is there any significant risk of international travel or trade restrictions? In addition to these 4 criteria, there are also 4 events which are always notifiable, and these are smallpox, severe acute respiratory syndrome events, wild-type poliovirus, and human influenza caused by a new subtype. In addition to our IHR event notifications, we also have event-based surveillance activities ongoing, and this is mainly through the epidemic intelligence from open source system, which is a dedicated system we use for media scanning of potential pieces of information. So on a daily basis, our public health intelligence analysts scan this system, which processes information from online news and social media, from government and official websites and blogs and expert groups. The system then applies natural language processing tools and AI that facilitate screening of this information for signals of interest. Next stage in our public health intelligence activities involves verification, and this involves a number of steps, including signal triangulation, triage and assessment, signal verification. Now, in terms of the first part, signal triangulation, the public health intelligence analysts would do this against other reports using information about previous trends and occurrences around that particular event, and would review contextual information. And this can really vary depending on the context and the hazard under consideration. And in the bottom right hand corner is some of the many different pieces of contextual information that we would consider when doing this signal triangulation. These include, for example, socioeconomic factors, information about human mobility, information about the political context, and importantly the cultural norms and traditions. All this information would then be used to triage the signal, and we consider 4 categories when triaging a signal: whether we would continue to monitor it in real time, whether we share it with others for awareness and for any actions on their behalf, whether we request further information, or we undertake a verification request. And a verification request can be under the International Health Regulations to the Ministry of Health. And when we're undertaking signal verification, this is a multi-step process that involves collaboration with many stakeholders. This is the key one being the Ministry of Health, but also with other technical experts and partners that are working in the field. And this can involve a field investigation, going to visit the site where the signal report is coming from to better understand what the situation is on the ground. The key questions that are asked in all these steps are always around some of the key epidemiological principles in terms of information around the hazard, information around the time, place and person affected, information about the testing that's been undertaken, and the case definitions in use. So once we have verified that an event is happening and it has been reported to us under the International Health Regulations, the next step in our public health intelligence activities is to undertake a detailed rapid risk assessment to assess the risk of an event to adversely impact the public health based on the likelihood and the severity of the potential consequences. This process uses technical expertise across all levels of WHO, with consultation of external experts as necessary, in particular our colleagues in the One Health tripartite, so FAO and WOA. And this is an in-depth assessment on the information available and reflects WHO's independent assessment, including what a country's current capacities and vulnerabilities to control the outbreak and the event are. One of the key outcomes of the risk assessment process is the decision to activate the WHO emergency response framework mechanisms, and this includes recommending setting up a grading discussion to provide more in-depth support to a country for a response, and importantly, whether an event needs to be referred to the IHR Emergency Committee for consideration as a public health emergency of international concern. Now, WHO's rapid risk assessments are based on an external guidance document, which is shown here, but it is an internal document. However, recently this year, we have developed a website where selected rapid risk assessments are available publicly to support countries in their own assessment of the risk of a public health event. And I've included here the web address for that. And then a key part of our public health intelligence activities is how we alert others to the fact that a public health event is ongoing so they can enhance their preparedness activities. We regularly share information on confirmed public health events to our member states through a secure platform called the Event Information Site for the IHR National Focal Points, which enables us to share information early and confidentially with member states. The information is compiled by technical experts across the organisation and is sent to the member state where the event is occurring for a 24-hour consultancy for accuracy. We published nearly 150 EIS bulletins and announcements last year to support countries in their preparedness and their readiness activities. We also share information on new and ongoing events to the scientific community and to the public through the Disease Outbreak News webpage. The DONs were actually first published more than 25 years ago now, and over the years have become a key WHO product for providing information to the general public. As well as a summary of the known epidemiology of a public health event, it also includes information on WHO's assessment of the risk of that event and, importantly, WHO's advice. Again, it's a multi-stage process in developing the disease outbreak news. But we also utilise other forms of information sharing. For example, specific situation reports like the bi-weekly MPOX SITREP or the monthly cholera situation report. And we also have information on our emergency dashboards or event-specific dashboards. So I hope this has given you a bit of a flavour of some of the public health intelligence activities that we undertake on a daily basis to detect potential public health events of international concern to support global health security. But to give you a little bit of a flavour of the number of events we're talking about, currently as WHO we're supporting countries to manage nearly 400 ongoing events and emergencies worldwide. And of these, more than 30 are events that we have graded, so providing extra WHO support to the country through, for example, deployments of technical experts or partners to support in particular activities. So I hope I have been able to describe today briefly how WHO undertakes public health intelligence and how the early warning of international public health threats is really a key function of what we do as WHO to enable a rapid response and support readiness activities, thereby enhancing global health security. However, there are a number of key enabling factors, and I don't have time today to go into these, but these include, for example, modernised information systems and technologies, including better data linkages, data systems and support globally, improved point-of-care diagnostics, the importance of collaboration, trust and communication, and lastly, how important highly trained teams are that reflects the multidisciplinary, multicultural, multifaceted world that we cover. This leaves me to thank you again for inviting me to being part of this conference, to also apologise again that I'm not able to be with you in person. But I really wish you a very successful conference, and please do contact me if you have any questions following this presentation. Thank you very much.
There you have it.
We don't have her here, and she's bang on time almost. We've got only 2 minutes, but Patrick, should we invite people to make some comments that we can capture and forward on to her?
Well, I did see a hand go up in the chat somewhere. That hand seems to have gone down again. So whatever that was is obviously resolved. If you do have any questions for Esther, her email was in that video there, and I can drop it into the chat for you if you would like to put them to her directly.
Okay.
Or you can send them to us. We will forward them to her if you want to.
Right. All right. Before we move on to our second set of speakers, I'll remind everybody that in the chat you will find the Mentimeter login and code so that you can participate in our questions for the day, which revolve at the moment 2 questions around surveillance and how you would divide up your spending if you had the money. What would be your priorities? Thank you, Patrick, for putting that on there as well. Give everybody a second to whip out their camera, should that be your preferred method. All right, I have seen Andre and Lewis lurking in the background, so we know that I've got 2 live speakers coming up. So Andre Fideli and Lewis Molloy are with Public Health Wales, based in Cardiff, and they're going to be talking to us about their work designing with purpose and some of the dashboards they've been developing in primary care. We won't mention the rugby, especially not the world rankings at the moment, because that would just be bad form, especially for us, for New Zealanders. So I will invite Lewis and Andre if they'd like to put up their slides.
Thanks very much for the introduction and for the only brief mention of the rugby. Just check you guys can hear me okay?
Yeah, you're good.
Great. I'm just going to share my presentation, and if you can just tell me if you can see with the notes or not, so I know if I need to flip it.
It's the notes. Yeah. It's the speakers one. There we go.
Yeah. Just slides?
That's the one. Yeah.
Perfect. Thank you very much. Yeah. So my name's Louis Molloy, and as mentioned, I'll be presenting with my colleague Andre Fideli here today, all the way from Wales. It's just about 10:30 at night here, so slightly different on the timings, but thank you very much for the opportunity to speak, and looking forward today to have a chat with you guys. So as mentioned, we're going to be talking about some of our dashboards. I'm going to start with just a quick overview, the contents we're going to talk about today. I'm just going to briefly cover a little bit about who we are, talk a little bit about public health in Wales generally, and then primary care specifically. What a primary care cluster is that's the focus of the dashboard we built. We're then going to go through the process of building the dashboard, what it means to be what we call agile, and what it means to be user-led. And then I'll hand over to my colleague, Andre, and he's going to give you a demonstration, a live demo of the dashboard, so hopefully no technical issues with that. So who are we? So we're public health intelligence analysts, and we work for the Observatory of Public Health Wales. So the idea of what we do, we provide data analysis, evidence finding, knowledge management, things like that, to help support decision makers and the public with public health information. We're a team of over 30 analysts, and we've got senior, advanced, and principal analysts, and we're split across 4 sub-teams with various projects in various domains of public health, disease prevalence, cancer data, and also primary care data, which is what we're going to be talking about today. So have a little bit of information here for the background about the current landscape of public health in Wales. A couple of key things worth noting. So Wales is the oldest age structure in the UK. Obviously, it's quite common in a lot of Western nations now to have this aging population, and Wales is the oldest structure of the UK nations. It's England, Scotland, Wales, and Northern Ireland, with consistent low birth rates. We're also a lot more socio-economically deprived than England, and these clear and continuing health inequalities that come along with that. And around a third of people in Wales are following less than what we call the 3 healthy behaviours. So that's not smoking, not drinking above recommended guidelines of alcohol, eating at least 5 portions of fruit and veg a day, being physically active, and having a healthy body weight. As many as 1 in 7 adults smoke, and there is a huge backlog of patients. As of January 2023, it was approaching 600,000, which is quite a lot of patients on a waiting list for a country that has just over 3 million people. So Wales, as many countries, is facing its troubles. And specifically primary care in Wales. So I'm sure many of you are aware, if not all of you, that primary care is the first point of contact for health concerns. So it can include services, general practitioners, GPs, community pharmacists, dental services, optometrists, and increasingly these multidisciplinary teams, including physiotherapists and pharmacists, mental health practitioners, all working together within a community. Welsh Government places a really crucial role on primary care, and the idea is to shift care from hospitals to the community and primary care centres to make services more accessible and a little bit more sustainable. This leads into the role of clusters, which I'm going to talk about a little bit in a minute. But first, I've just got a little comparison between Wales and New Zealand. I just want to preface this slide with this. Of course, I've done my due diligence as much as possible, but there's many of you in this room are going to have far more knowledge and expertise around what primary care looks like in New Zealand and these differences. So if there's any mistakes here, I apologise, but I've tried my best to get a fair comparison. So funding models, here in Wales, it's fully tax funded. Everything's free at a point of use. Whereas in New Zealand, there is a mixed funding. So examples there include GP access and pharmacy services and prescription charges. So GP access and prescriptions are both completely free in Wales. New Zealand has some sort of co-payment system, so it seems to vary in price. And similarly with prescriptions, they do seem to be subsidised. Similar with enrollment here, you register with a specific GP practice for free, whereas in New Zealand, you enroll with this, what seems to be called a PHO, Primary Health Organisation. And similarly, there are quite a lot of similarities, as you might expect. So both digital access, mental health integration seem quite similar. Similarly, pharmacy services, both quite broad roles and trying to increase the role that pharmacists can play in minor illness care and vaccinations, and similar challenges as well, staffing shortages, rural access gaps, things like that. But a key difference to focus on today is the primary care network. So Wales works with what we call primary care clusters, population-based teams, and there are 64 of those versus New Zealand's PHOs. So a primary care cluster is a service, a group that brings together all of those primary care services we mentioned, so GPs, optometry, pharmacies, things like this, across a geographical area. So they cover a smaller population than a health board, typically 25 to 100,000 people. And the idea is that working as a cluster ensures better coordinated care for communities. So as I said, they're population-based, not geography-based, which is why you get such a huge variation in sizes. So you can see here this map of Wales, for those of you who aren't familiar. Down south is where the heavy concentration of the population lives. So you can see the clusters here are much, much smaller geographically compared to a lot of mid Wales and some of them in North Wales, because the population density is so much higher. It's also worth noting that this map is a couple of years out of date now. These boundaries do shift ever so slightly, as obviously population within a cluster may change, individuals moving in and out, births, deaths, things like that. So these boundaries are shifting constantly, but this is the most up-to-date map, and they don't tend to shift a lot. So why do we want to look at cluster level data? Well, to put it simply, we need to focus on it at that granular level to make sure we don't miss differences that we would get if we just looked at health board data. So I've taken an example here, and I understand that the areas won't mean much to many of you in this talk, but to point it out, there's Torvine North, Monmouthshire North, and then places called Blaenau East and West. Now those are down in this corner here, so you can see it's these four clusters here. So you can see there's a large geographical difference size-wise for some of them, but they all share a border, and you can tell by the colour they all share the same health board. But when we look, this is data taken from the dashboard. If we look here at mortality, for example, all-cause mortality, age standardised rate per 100,000, there's over a 25% difference between some of these clusters, between Monmouthshire North and Blaenau East and West. Now that's a huge difference in all-cause mortality, and that's data that would be missed if we only looked at it from a health board data. So that gives you an idea of why we want to look at cluster level data, and I'm just going to talk over what we did to design this dashboard. So as we talked about, the idea is it's user-led, and we work with something we call Agile here at Public Health Wales. What that means is we want to work with our users, and we want to produce the right type of products in an iterative manner. So it's not one finished product at the end. We're giving it to them as we can. This is an example taken from Miro, if any of you are familiar. It's like an online collaboration platform where we've invited some of our user group members. So we've got a user group of over 90 people. They consist of people who work in primary care, whether that's GPs, pharmacists, primary care leaders, and essentially got their input on what they wanted to see from the dashboard. So you can see here, for example, we gave them a bunch of different indicator options, and they made it really clear just by putting these little stars what was a priority. So you can see here, chronic conditions and long-term illnesses, mental health, demographics were really high priority, fruit and veg consumption, journey time, emergency service use, much lower priority. So it allows us to focus on what the users actually want from this data. So this is the sort of rough timeline of what we produced. So when the project started in September 2023, after some user groups, we had some rapid output. So this was data that our users said they wanted as quick as possible in almost any format we could give it to them. So it was simply a case of produce some Excel sheets with the data in that they could have access to immediately. We then moved on and put that data into a dashboard, which you'll see a demo of in a second. And then gradually over various months, we added more data. So Feb 2024, we added mortality by condition and some deprivation data. In May, we added avoidable mortality and some trend data to the mortality by cause. In July, we added chronic conditions data. September, some emergency admissions. And then March 2025, there was a phase 2 published, which was a sort of a narrative indicator tool. So you can see what doing this in an iterative manner means. If we wanted to wait until there was a final project, this was when the sort of first phase of the dashboard was finished in September 24. it's a whole year that our users wouldn't have had access to some of this data because we waited until we had an end product. Instead, we gave it to them in bits and pieces, and it meant they could access things much faster. So that's me done for now. I'm going to hand over to my colleague, Andre, and he's going to give you a live demonstration of the dashboard.
Thanks, Louis. Just going to share my screen to give you a brief tour of the primary care cluster dashboard. So yeah, as Louis mentioned, we first released this dashboard back in November 2023, and there's been numerous iterations since, adding new datas and new features to the dashboard based upon the user's requests. So this dashboard was created using our Shiny code, and it's available to view publicly. We're happy to share the link to the dashboard in the chat in case anyone wants to access it. But once you open the dashboard, you'll be taken to this homepage. And within the homepage is this little section here which describes the content of each of the different tabs within the dashboard. And then just below that, we've also got a feedback form that users can fill out because we're always keen to better understand our users' needs and how we can improve this dashboard. So we'll first take a look at the indicator menu page. This includes a table with sources of primary care cluster level data, not just within this dashboard, but also external data sources. So using the search bar on the right-hand side, say if I'm a user and I'd like to search for vaccination data, and then that will display the vaccination data that they'll be able to access. Fortunately, we don't have any vaccination data within the dashboard, but there are some external sources that users can access. So if I just click this drop down here, I can access this influenza data using this link we provided, as well as some further information on that data, such as the source of the data when it was most recently refreshed. Moving on to the charts and tables tab, this is where all of our indicator data that we produced is housed. So we have individual tabs for dedicated to each indicator. Fortunately, don't have the time to go through all of them, but just to give you an overview, we've got data on population, age, sex breakdowns, low birth weight, breastfeeding at 10 days, mortality, avoidable mortality, chronic conditions, and emergency admissions for a variety of conditions. So we'll take a look at the mortality tab as an example. We can either look at latest or trend data. So we'll take a look at some trend data. All of our indicator pages are laid out in a similar fashion. So on the left-hand side, we have some drop downs where you can select the geographies, the conditions, and the measures, and then that will update the chart on the right-hand side. So in this case, we're going to be looking at some mortality data, age standardized rates for Wales over a time period of 20 years. But using the drop downs on the left-hand side, I can select different geographies. So the clusters are all sectioned out by the health boards that they sit in. So I'm going to look at a couple of clusters which are in the same health board. So I'm going to compare Monmouthshire North against Gwent West. And then I'd like to look at diseases of the respiratory system, and I'll look at age standardized rates per 100,000. So that will update the chart here on the right-hand side, and you can see a couple of things here. Blind Eye Gwent East has higher rates of diseases of the respiratory system across the 20-year time period, and it's actually dropping for both of the clusters, which is good to see. If a user wanted to use this chart, maybe in a report or a presentation, they're able to download an image of this chart using this button here, and they're also able to download an Excel workbook of the data as well. Just below that, we've got a toggle to show some technical info for the indicator, such as an indicator definition, the data sources used for the indicator, and some further information sort of around methodology, etc. So the bulk of our data is output using various versions of charts, but we've also produced a couple of maps which you can access in the Maps tab. We've only produced some maps on deprivation data, so that the number of the cluster population and the percentage of cluster population in the most deprived 20% of Wales. So we've got a couple of heat maps here, and the darker areas are where there's higher concentrations of the population in the most deprived fifth of Wales. There's certainly potential to produce some more maps for some of the other indicators that I've shown you in the dashboard, but maybe if we get some feedback from stakeholders, that is something that we could potentially do. Final thing to look at within the dashboard is the technical info tab. So there's a few sub tabs within here just containing some more information about the boundaries that we've used, some definitions based upon the different populations, because we've got registered populations and resident populations throughout the data in the dashboard. Further information on the data sources that we've used and where we may have had to include some suppression. An interpretation guide as well for some of the methodology used within the analysis, and also a glossary of some key terms. So as Louis mentioned earlier in this year, we released phase 2 of the project. So this was to complete the development of an additional user-led primary care cluster population health product aimed at supporting additional user personas and helping to inform planning decisions. So similar to what we did with the dashboard, we consulted stakeholders through various user groups over the course of a few months to gather their thoughts on how they'd like us to shape this product. So the consensus was to produce a summary profile with a selection of key indicators for all clusters within a health board simultaneously, and users can also compare the indicator data with health board data and Wales-wide averages, and as well as including a brief narrative highlighting key findings from the data as well. So this indicator summary profile is available to view publicly, but you can also access it using the link that we provided in the header of the dashboard. So if I just click this link here, it will load the indicator summary profile. This was also produced using our Shiny code. Just take a minute for that to load. So here is the indicator summary profile. So yeah, using the drop down here, you can select the health boards, the 7 health boards in Wales to display the data for the clusters within the health board. So I'll select Cardiff and Vale, and you can also select whether you compare to the health board average or the Wales average. In this case, I'll just stick with the health board average. And then that will update the table below. So it's got the data for 14 key health indicators from a variety of indicators, avoidable mortality, chronic conditions, emergency admissions, looking at conditions such as diabetes, heart failure, etc. And using the legend we've got here, you can compare the cluster data against in this case, the health board data, whether it is significantly higher, significantly lower, or comparable to the health board data. So just using an example here, you can see that the cluster Cardiff South East has significantly higher outcomes for many of the indicators, which is a stark contrast to Cardiff North, which has significantly lower outcomes for a lot of the indicators when comparing against the health board averages. And a potential reason for this, if we see this top indicator here, in the top row, the population living in the most deprived fifth is at 39% for Cardiff South East, compared to just 3% for Cardiff North. And those sort of key findings are then displayed in the narrative above here. As well as a feature that's included in the dashboards, that's also included in the indicator summary profile, you are able to download the data with just a click of the button here, and you're also able to download this table and narrative as a Word document just by the click of a couple of buttons. Finally, just to mention as well, the indicator summary profile and the dashboard are fully translated into Welsh, and you can change to English or Welsh using the toggle in the top right up here as demonstrated. So that's the products that we produced in the last couple of years. The next steps for us, as Louis mentioned, the cluster boundaries do change usually on an annual basis, and Welsh Government have recently released new geographical boundaries. So we'll need to ensure that these changes are reflected within the dashboard data, and we'll also be looking to update the data in the dashboard to include the most recent time period. As well as that, we'll be looking to potentially add further indicators and also continue involving stakeholders and seeking their feedback. So thanks very much for listening. We're happy to answer any questions, and just to echo what Louis said, really appreciate the opportunity to give a presentation at this conference. Thank you.
Thank you very much for that awesome talk and excellent timing. Thank you both very much for that. Peter, do you have a question?
Yes, I do. Thank you very much, Lewis and Andrew. I thought that was really interesting. It is very interesting. I have in your clusters, I would think you would have some harder to reach populations. Do you target the harder to reach populations with any cluster, so like by age group, ethnicity, or maybe demographic area? Do you do any lower level analysis?
Unfortunately, with a lot of the data for our indicators, the sample sizes are very low once we start breaking the data down by age and sex. So for most of the indicators, we don't break it down to that sort of level. There are one or two indicators in there, such as for chronic conditions, where we are able to break it down by sex, for example. But unfortunately, we don't go much lower than that. We are looking to potentially look at what's called deep end practices, which is, I believe it's like the highest, it's practices that live in the highest fifth of, or the lowest, the most deprived fifth of practices in Wales. That is potentially some data we might be able to include in the coming months to look at sort of more deprived areas.
Thank you. We have similar issues here.
Kerry, you've got a question?
Thanks, Andre and Louis. That was an excellent presentation. As Peter said, thoroughly enjoyable. It must be a considerable advantage for you people to be in one area producing such wonderful analysis and information. I mean, why I ask that is that in New Zealand, that kind of thing that you're doing is spread amongst a number of agencies. Or are you the only one, and are there others that are doing similar things in Wales?
Yes, there are one or two other organisations across NHS Wales that are producing cluster level data and sort of dashboards similar to this. As far as I'm aware, there's a couple of other dashboards, producing data at cluster level.
Thank you.
Great. I've got a couple of questions, but just before I ask them, can I just ask if our next speaker's here, Patrick? Or is it a video?
Yeah.
Let me take myself off. Yes, our next presenter is pre-recorded, so they are here digitally, if not in person.
Sneak in one question. Guys, I think sharing your code is awesome, and it's showing so many other organizations the way forward. It's the new Wales government policy.
Sorry, could you repeat that question?
Andre? Yeah, I think sharing your code is just an awesome way forward. Thank you very much for doing that. Is that the government policy now in Wales?
To share the specific R codes that we've used.
Yeah.
I don't know if it's part of policy, but it is certainly something in Public Health Wales that we're looking to do further. I know that some teams across the organisation have started doing that, and it is something that we're keen to do, to share this code publicly and share it with other organisations. We know, for example, NHS Scotland do that a lot, and we're trying to use that as an example.
No, awesome. Thank you very much for leading the way, guys. Which is in England soon.
That's very unusual to share code with another organisation, so well done.
Well, the cousins across the pond pioneered this, didn't they? Anything publicly produced is shared. Code, data, anything. It's just the way we should go. Yeah, it's the future. So good on you guys. All right, our next speaker, so that we maintain our time, Lennie Lindberg, who's it appears has prepared a recorded presentation for us. He's the head of the Department of Communicable Disease and Control and Health Protection in the Public Health Agency of Sweden. And he's going to be presenting his views on health intelligence in action, sort of a Swedish perspective. All right, Patrick, when you're ready.
Right.
Hello, everyone. Greetings from Sweden. My name is Lennie Lindberg. I am the head of department for communicable disease control and health protection here at the Public Health Agency of Sweden. Thank you so much for the opportunity to be able to speak to you today. I am here to give you a brief overview of one of the health intelligence programs for communicable diseases that we have here in Sweden. Sweden is geographically a quite large country, with the most populated of the Nordic countries with 10.5 million inhabitants. It's 1,500 kilometers from north to south, and we are divided into 21 counties or regions and into 290 municipalities. Even if we of course have a lot of laws and regulations on a national level, each region and municipality hold their own elections and are self-governing in some areas. The Public Health Agency of Sweden, which is under the Ministry of Social Affairs, have the overall responsibility for the country's communicable disease control. We develop regulations, recommendation, and provide guidance for healthcare professionals, and do this in quite a broad sense. We also have the responsibility for the vaccination programs and the guidance that comes with that, for the emergency preparedness for outbreaks of communicable diseases, the responsibility for national stockpiling of communicable disease medications. We monitor and follow antibiotic resistance, infection control, and healthcare associated infections. And we also work to prevent HIV and STIs. In Sweden, the responsibilities for infectious diseases is shared among different levels. On a national level, we have the Public Health Agency of Sweden, which serves as the national coordination body for communicable disease control. We also are responsible for the epidemiological and molecular surveillance. We provide coordination of outbreak investigations. And we also serve as the international contact point. On a regional level, we have the county medical officers. They are independent authorities and they are able to implement measures to prevent the spread of infectious diseases within their region. And they also have the operational responsibility for infectious disease control within their county council. And they also work with epidemiological surveillance, mostly on a regional level. And then we have the municipalities on their local level. They provide environmental investigations, they serve the schools, and they also care for the elderly and disabled within this area. In Sweden, we have the Communicable Diseases Act. And as you can see on this picture, those two that are on the left side are those who are dangerous to society and dangerous to public health. Examples of diseases that are dangerous to society is SARS and smallpox, which has potentially devastating consequences for society and may call for extraordinary precautions. We also have those who are dangerous to public health. There we find mpox, cholera, hepatitis, etc. Totally among 30 serious diseases or agents when individual restrictions may be issued. We also have those who are more far to the right, which are mandatory for contact tracing, for example measles, and we also have those who are only notifiable, such as malaria and tetanus. In total, about 60 diseases or agents that then needs to be reported to the county medical officer and the Public Health Agency of Sweden. And as an example, COVID-19 was classified as dangerous to public and society in January 2020 and reclassified as only notifiable in 2022. In order to fulfill our surveillance work, we have something called SMENET. That is the National Notification System for Notifiable Diseases. So data is collected from identified cases of notifiable infections, and that is put into SMENET. The system receives information from both clinical notifications and laboratory notifications. A new version of the system was launched in 2021, but the system has been available since its first version in 1997. SMENET is co-owned by the county medical offices and the Public Health Agency of Sweden. And at the agency we have a team of epidemiologists and IT specialists that work with maintenance and improvements of the system and provide support to their users. It's available for the county medical offices who are responsible for the data that comes from their region, and they can also complete and correct case data. They can only access data from their own region, and we at the agency can access all national data. And this is the primary tool that we use for coordinating outbreak investigations. There is also a working group of regional users, including laboratories and CMOs, who together with the agency evaluate and make priority ranking of suggestions of improvements. It could be both correcting errors and bugs or adding new functionality. SMENET has a lot of users, and there is a guide available that describes how to report cases step by step. At the Public Health Agency of Sweden, we provide a support function with a dedicated mailbox that is staffed all weekdays. We also, as you can see on the right-hand side here, we have case definitions available for all the notifiable diseases, and these are revised on a yearly basis. So SMENET serves as our primary tool for information for action. A doctor may send in a clinical report. It could also be a nurse or a social worker. And then the laboratory also sends all the positive lab reports. And that comes to the county medical officers that are responsible for confirming the reports, and also comes to the Public Health Agency of Sweden, who also confirms the reports. The CMO acts out on the case information given around the case, and the Public Health Agency uses this data to be able to investigate outbreaks and different trends. SMENET is also central when new threats arise and we need to scale up our activities. This picture illustrates how we worked during the COVID-19 pandemic. SARS-CoV-2 was made notifiable early on, and all data was reported to SMENET. Using the information in SMENET, we could link the information to other data sources, such as registers holding information on hospitalizations, how the pandemic was affecting the elderly care homes, and also affecting people that were in need of in-home assistance. We also have the possibility to follow the pandemic through the Swedish Intensive Care Registry, and we also had information from the Swedish Tax Agency who recorded a 30-day mortality. And further on, we could also use the National Vaccination Registry to see the vaccination status of the inhabitants in Sweden, and together we got the picture of how the COVID-19 pandemic was affecting our society and how the vaccination work went on. The data is not only collected and used for our own actions, but also reported nationally and internationally in several ways. And here you see some examples of how data is disseminated. We, for example, have reports on the sales of antibiotics and the occurrence of antibiotic resistance in Sweden. We have information about current outbreaks given both to the public and to the healthcare system. and we summarize these in yearly reports. We have a lot of ways of reporting events and reporting and collecting data. For example, we have the officer on duty and a clinical microbiologist on duty who are there 24/7. We have daily internal meetings with representatives from all departments, and we also have weekly digital meetings with the county medical officers. We have a weekly phone conference organized by the Civil Contingencies Agency, and that supports information sharing between national and regional actors from several different sectors. That conference also can address issues that could affect other stakeholders in order to support different ways of preparedness. The Public Health Agency also coordinates when several regions are affected or reporting cases in suspected outbreaks. And we also have what we call the SONOS collaboration group, and that is gathered when there are zoonotic events that need actions, that need information exchange, or are in need of decision making from several agencies that have interests in the situation that is at hand. Another source of information is the National Vaccination Registry, or NVR, that has been in use since 2013, and through the system it is mandatory to report different vaccinations given within the National Vaccination Program for Children and within the National Vaccination Program for risk groups. Although COVID-19 is not formally part of a national vaccination program, it's also registered in the NVR. What is reported into the NVR is the personal ID, the date of the vaccination, information about vaccine, such as product name and batch number, the dose number for COVID-19, and the name of the responsible healthcare provider. Into the NVR, we also retrieve from the Swedish tax agency the registered county and municipality of residence and the date of birth. The National Vaccination Program for Children provides vaccination against 11 diseases in Sweden. It is offered in primary healthcare and through school healthcare. The coverage is quite high, and we are proud of that. It's also quite uniform throughout the country. For example, around 85% coverage for Rota and HPV, and around 96% for other diseases. I also want to say a few words about the wastewater surveillance program. Currently, data is collected through wastewater surveillance for SARS-CoV-2, seasonal flu, and RSV. And this is done in collaboration with the Swedish University of Agricultural Sciences. For SARS-CoV-2, we are monitoring virus levels and performing sequencing to detect different variants. And currently we are evaluating if wastewater surveillance is more accurate than the reporting system in SMINET in picking up early signs of an outbreak. And preliminary data shows that it could be seen as a complement, but very important to have this surveillance system set up as a part of the preparedness work that we are doing. The coverage right now is covering 43% of the population through 18 wastewater plants. So as a summary and to highlight some key points for the health intelligence system is that we need contingency and preparedness in a larger scale before because of the ever-changing safety situation. We also find it crucial to have a digital and interoperable infrastructure. We need to address disinformation in order to keep a high vaccination coverage among both children and adults. And finally, we need to plan together, we need to practice together, and we need to work together. And everything that has or that needs to function in a crisis also has to function in a more normal setting. Thank you so much for your attention. You can visit the Public Health Agency of Sweden's website and the English version of it through this link. And you can also follow us on LinkedIn, where we are very much active, although mostly in Swedish. Have a great conference, and thank you.
Another very interesting one. We'll have to cluster all those ones from WHO, Mark Jacobs, one on the Pacific, and the country-based ones together when we put those papers up online. Just to remind colleagues, and then we have a discussion and Mentimeter review point. Now the Mentimeter details have been shared a couple of times. They're in the chat. We've only had a few people actually answer the questions, but it'd be kind of good that you give it a try. It'll only take a minute or two to do that, and then that'll hopefully add some grit to the discussion that we're going to have. Right. Last but certainly not least, we've got Matt Halstead, who's a principal data scientist from New Zealand's Ministry for the Environment, and he's going to be presenting some joint work with that he's done with a colleague, Professor Heather McLeod, and they're looking at something that's really interesting to me as a climatologist, especially climate projections for geographies that are meaningful to healthcare. Here, more stuff that's meaningful to us. I like it. Matt, welcome.
Kia ora. Yeah, so I'm at Ministry for the Environment. So I'm actually here just to run through a presentation that Heather's put together based on some of the work that she's done in her own research prior to MFE, but that now is sort of been extended as we bring climate projections into the mix. So I'll run the slideshow, and then following the slideshow, I can answer questions about it and then go into any more detail about the availability of this data and how we can help people use this data. So just bear with me. Okay, so let me know if you can see the presentation, and then I would better start it. Okay, and also let me know if the audio does not start soon as well.
Tēnā koutou katoa. This is Heather McLeod speaking. The time that you gather for the conference, I'm going to be traveling in some fairly remote areas, and so I have recorded my part of this joint presentation. In recent years, I've had the great fortune to learn from and work alongside James Rennick. He says climate change, it's seemingly simple to ask, but it's really complex to answer. Is climate changing noticeably? And he and I have a joint paper out with our answer to that particular question. We also took the results from that research and shared them with E. Hines, and Patrick created the wonderful reports that you can download. So at a territorial authority, TA level, you can choose a particular TA and get a report with 10 composite measures of climate over a 50-year period. There were several things I think we got right in that work. Firstly, that you can see the results by the seasons. This is the report for cold in the Ruapehu district, for example, and you can see the summer, autumn, winter, and spring. It gives you an opportunity to contrast the seasons, but also to see how much they're changing. We also had one value for each year in that period, and that gives you a chance to see not only the trend, but also the variability in the climate. And that's really important from a research perspective, is to understand how variable the historical climate has been before you look to the future. We have figures calculated over a 50-year period, which is a really useful time period for seeing both the variability and the trends. And the measures we used can be decomposed into standard metrics of extreme weather. So for example, frost mornings, the number of days with minimum temperature under 0 degrees. But every time I presented this, I would say, imagine that we could also see the projections, say for mid-century and end century, and put them on the same axis and see where they lie relative to what we know of the historical climate. In order to get from the data that we received from NIWA down to an amalgamation like a territorial authority, we need to do spatial amalgamations, and we developed two techniques during the course of that research. The first one we called lassoing. Here I'm illustrating lassoing for North Canterbury. The grey dots here are the virtual stations, the 11,491 grid points that are part of what is called the VCSN grid, the Virtual Climate Station Network. If you take the blue line, which is the shape of the Hurunui district, and effectively think of it as a lasso, and we capture all the points that lie within that blue line, then the climate for the lassoed area is simply the average of all those VCSN stations. This gave us access to a whole range of spatial boundaries. And so, for example, we could look at regional councils, territorial authorities, we could look at Te Whataora health districts and regions, we could look at climate zones, we could look at iwi areas of interest. In fact, you could take any polygon that you can visualize in ArcGIS and we can create climate for that. But that technique doesn't work for all geographies. And one of the things we were most interested in doing was finding a way to get climate at the same sort of resolution as we might want to look at health data or data about vulnerability. And so we have a second technique, which we call the Thiessen method, which makes use of what are called Thiessen polygons. Some people may know these as Voronoi polygons. Here we illustrate that technique. Here are the grid points, as before, and we put a polygon around it using ArcGIS, and that enables us to see the areas of influence of those particular points. Gisborne, as an urban area, didn't lasso any single point, but by using these Voronoi or Thiessen polygons, we can say what proportion of the Gisborne area falls within each of them. So it's effectively an area-weighted approach to calculating climate. At the end of that research work, a group of us got together and worked up a plan for updating the work in future. It was at the time that Stats New Zealand had just published the Geographies for 2023 that they were planning to use for the 2023 census. And we knew that June Atkinson, the part at the University of Otago, was planning to do NZ-DEP 2023 using that census, that Kylie Mason at E. Hines was planning to do an update of the social vulnerability indicators to use the new census, and then I would bring to the party the details of climate and particularly future climate, if we could get hold of them. The really exciting news is that NIWA has partnered with the Ministry for the Environment to put these new projections into the public domain. The projections are called the NIWA CMIP6 downscaled and bias corrected projections. That's a real mouthful. Let me give you an understanding of just what happens. The big global climate models typically have a resolution of around 100 kilometers. And so with our fairly narrow islands, you only get a few blocks of climate using those models. Previously, in what was called CMIP5, NIWA was able to downscale to a resolution of about 30 kilometers, which helped to get more of a sense of the mountains of South Island and North Island. But in this version, CMIP6, which was used for the IPCC 6th assessment report recently, NIWA has been able to go down to a resolution of 12 kilometers, and that gives a much better sense of the mountains. So those particular weather features like strong westerly winds, heavy rain along the west coast, dry along the east coast, are much better represented in these new models. NIWA then takes that 12 kilometer resolution, does some further bias correction and downscaling, which they've described in a document, to come to that roughly 5 kilometer VCSN grid that I spoke about. And that's what's exciting. The techniques we used on the historical data can equally be used on the projection data. And so what is in the public domain that we can now put together? There's a list of 25 climate indicators. There are values and change in values. There are 4 scenarios, 4 warming levels. There are in fact 2 base periods, although I prefer to use just the most recent one. There are 3 future periods of 20 years each. There are 6 models, and this produces 1 value for each future 20-year period. Values are available for all 11,491 grid points. And the work that I've been doing is to aggregate these geographies to various things that make it useful for us to look at further health research or vulnerability and resilience work. So the 10 aggregated geographies effectively are based on Stats New Zealand boundaries. To understand a little bit more about the climate models, NIWA has described the process of selecting models. 6 of them out of a total range of around 52 were chosen. The most important thing from a research perspective is that the range of results is not a minimum and maximum for what might happen. It's simply 6 points within the range of results. There's also a multi-model mean, which is the mean of the 6 models that were chosen. So it's an enormous amount of data and really difficult to think about how to visualize it and analyze and get meaning from it. I'll show you what works for me and what I've discussed with James and that we find is helpful. This, for example, is maximum air temperature, TX. What we do is to put the base period here in dark blue, the 3 future periods here in paler blue. The bars here then represent the multi-model mean, and on top of that we have 6 models as circles. This particular picture is for summer, autumn, winter and spring. As I say, I find it very useful to look at the seasonal effect and to always have the 4 on the same diagram if possible. That's for TX, the maximum temperature, but there are also extremes, and the extremes really matter when it comes to climate change. So we can look at, for example, TX25, which is the number of hot days exceeding 25 degrees Celsius. And we can see that, again, by season. And you can see here how the range really extends in summer from where it is at the moment to where it might be by end century. You can also see how the range of results from the different models has begun to expand as we go forward. There's also TX30, the number of very hot days over 30 degrees Celsius. Taking a different geography, the health regions, here we see, for example, the summer for the Northern region, Midland, Central or South Island together, and we can see what the future may hold for temperature and for maximum temperature. I often find it's really helpful to look at the relative values here. And you say, for example, what does TX25 look like in future, let's say for South Island? And you can see the number of days is actually much higher than the number of hot days you would get in the northern region at the moment. So that kind of relative assessment of what the climate might be like. Up till now, I've shown you just one scenario. There are actually 4 of them available. Some of the pictures about the scenarios are actually quite complex to work with, but I like this version from the IPCC, which uses warming stripes to show the warming in recent years. And then it shows 5 possible future scenarios. NIWA has provided the details of the top 4 of those. The very low scenario, SSP 1.9, is not provided because we've effectively blown through that scenario already. So here we can see temperature, TX at the top, TX25 at the bottom, for Te Manawataki for 4 scenarios. And the SSP 2.6, the low scenario, you can see the temperatures actually begin to fall. Same is true for hot days. And so that tells us all hope is not yet lost if we can bring warming under control. But if we don't, you can begin to see how those extremes will change or expected to change in future. There's a very good, relatively easy explanation of these shared socioeconomic pathways that you might find useful to explore. So from a personal perspective, what is on my agenda for future research? I would love to have the daily data, which is now in the public domain as well, and work up a whole range of extremes as we did in the historical data. That would mean one value each year rather than values for 20-year periods. I would love to do some more geographies. Iwi areas of interest are very high on my priority list: river catchments, ecological districts, species range, but any polygon is possible. And it's really a question of just putting them into ArcGIS and doing the calculations. So please, if you have any suggestions, I'd love to hear from you. I'm now going to hand over to Matt Halstead to tell you more about how you can access that data for your own research.
Okay, thank you for that. I thought I might just add a couple of notes, just listening through that again. I think there's one part that she referred to was doing all of this in ArcGIS. What I've been doing within the MFE sort of space is writing code to automate all of this processing. So right from the raw data all the way through to aggregated indexes based on different questions that you want to ask about different geographies. So part of what I wanted to sort of bring to the table here as well is that people are free to contact Heather and I, and then I'll be able to actually share some of the methodology and the code if people want to start repeating this in their own environments. You don't have to step through and do it manually in ArcGIS. The other part, just before I get to the where we have the data, is that I kind of realize that people are probably not too familiar with these scenarios and what they actually mean. So the way the CMIP6 climate model scenarios were derived this time was really around starting off with a shared socioeconomic pathway. So different ways that sort of countries could go in their geopolitical sort of direction, how land use changes, how energy efficiencies and energy use and sources change as well. And then on top of that, you can sort of start to apply a very particular kind of end result in composition or trajectory of composition of gases in the atmosphere. So given a base scenario, socioeconomic scenario, how could you actually achieve a particular kind of gas mixture in the future with the addition of policies or without the addition of policies? So the SSP RCP scenarios that we have in our data are these 4 here. And it's probably useful to note, I guess the general consensus is that we're sitting at around SSP2 4.5, which is going to lead to about a 2.4 degrees warming by the end of the century. There is a slight sort of return possible, that if the sort of climate mitigation policies start to strengthen and start to move into the ones we would have expected for this scenario, then we could actually start to return. But it will mean sort of a lot more of this moisture loading into the atmosphere and the heat loading, and therefore natural hazards and the results from that. These other scenarios here, we have the 8.5 as kind of another control or baseline, I guess. We hope we'll never actually achieve this, but really, if you don't do anything to mitigate climate change, and you continue on with this fossil fuel energy source, then we'll end up in one of these scenarios here. The data is available at this URL. It's a website that kind of goes through what the data is and how to access it. But right now, we're just preparing the release of the data that Heather talked about. So all of these aggregate data sets that we've put together, as well as the Voronoi Thesean polygons for people that want to use those as well. We'll be publishing Wednesday next week, and so this whole website will update to include that as well. So I just heard the bell now. What I'll do is just exit out of this and answer any questions that people have around us.
Got a couple minutes for questions. Well, as maybe the only climatologist in the room, let me ask you a question. So in the UK, the Met Office provides us with the ability to take that type of data and then use a weather generator to give us a sample, statistically relevant sample of a year, daily data. Is that going to be available to New Zealanders as well?
Yes. So I can just move to the website over here. So one of our data sets that we do actually produce is the daily data set. Right. So where all the indexes and things were generated from. So if I just kind of go to this diagram here, we have the daily data that's available on our website across these variables. And of course, these indexes and climate aggregates are derived from those variables. So that is all available. It's about 5 terabytes of data, but certainly we can help people, figure out how to use it and access it.
They're going to need that for forecasting heat waves. That's really interesting stuff in there. Peter's got a question for you.
Peter.
Thanks for coming along, Matt. I heard you mention moisture a few times. Is there any plans to start including rainfall or flooding or anything like that?
Yeah, so we do have the precipitation and these 99% percentile precipitation, but the real data set that's quite interesting is the high intensity rainfall data set that NIWA typically produces, and they're currently trying to produce that for the projections, which we will then release. So there's 2 data sets that will be coming over the course of this year. Within the next month, we'll have drought index. So I guess the opposite of mega rainfall events is the drought index, and how many months and things we'll end up spending in different types of drought and the duration of those. But these particular indexes here, the R99 p-val and p-val wet, are 2 that you can use as proxies for high intensity rainfall events. It's just not going to be as specific around the sort of probabilities and risks than the HERDS data set, the high intensity rainfall data set that NIWA can produce, but that will be coming as part of this.
That's very interesting, because we've had a lot of flooding on the East Coast, and some people even changing our name from Windy Wellington to Slip City. So maybe those rainfall things can help us a little bit.
Yeah, I think rainfall and drought are 2 very interesting indicators.
Matt, just to follow on from that, we've gotten a question in the Q&A asking whether or not PM10 and PM25 data might be available for New Zealand cities.
Not in our imminent
Daily.
Yeah, not in our imminent planning. So these ones here are the ones that NIWA have downscaled, and sort of if we want to add to any of these, it's quite a large piece of work for them to reprocess data and produce. If there's a good reason to, then we'll need to set up a contract to do that. These derived ones here, based off these, we either NIWA or MFE are able to help produce those. So we're really keen to hear about different kinds of indexes or extremes and things that people would like derived from this original daily data, but it's quite hard to add new variables here. It's not out of the question. It's really around the kind of I guess the desire for it and the financing to be able to run the model to produce those variables.
Do you know whether the water industry or the water providers are interested in understanding future flows into their facilities, particularly the sewage treatment?
Yeah, we assume they have. We haven't talked to them directly about it. There is still a relationship. So if you want very specific modeling, either at a higher resolution than the 5 kilometers, then you work directly with NIWA on those kinds of questions. But the local councils, with respect to their infrastructure planning, have certainly been very strong participants in, I guess, our requirements gathering and the kinds of data sets that we're producing for them. Well, I guess for everybody, the public, but in particular, they want to start integrating it into their risk analysis systems. But yeah, haven't heard anything specifically from the water care.
Anybody else out there have any questions? I mean, there must be some ESR people here who are using this already, presumably for movement of pathogens through the environment, perhaps.
Yes, absolutely. If you do have a question, please either use the raise hand button or drop it into the Q&A menu and we can get to you as soon as. And
also, if you have questions for the other fellows, Andre and his colleague, Louis, feel free to ask them. We've now entered the discussion session at the end of the thing, so we have plenty of time, just 2 groups from which to ask questions.
While we wait, if I could put out a call for Dr. Sarah Jefferies, that's Dr. Sarah Jefferies of ESR/ the Public Health and Forensic Science Limited New Zealand. If you're in our attendees list and you're not logged in under your own name, could you please raise your hand so I can upgrade you to panelist, please?
3 upgrades. That happens to doctors on flights. I didn't know it happened in conferences. Matt, while we're waiting for a question, can I just ask you how long you've had this level of detail for future projections available in New Zealand?
Well, there was CMIP 5. So I am talking under, yep. There was CMIP 5, which was out 3 years ago, but that wasn't made publicly available. I sort of had to contract NIWA. So this is the first time since mid last year that we've started being able to make this data available publicly. And that was through an MFE MB grant to be able to make it publicly available for this round of modelling. So yeah, we have a very good relationship with NIWA and they are very keen to make public as much as possible, which is great.
No, it's absolutely brilliant. I mean, we've been running a Mentimeter, asked people a couple questions, and one of the questions that's been asked, and I guess we could put that up at some point, was what's missing from New Zealand's health surveillance, and the response that's most popular, or not popular, but they've put in themselves, so we haven't primed it, is open data. That's the thing that people say is most missing, and funding being the second one. There's not a government function that wouldn't have that one listed pretty highly, but open data, that's an interesting one. And clearly Andre and Louis are feeding that desire in Wales. I mean, putting your code out there is about as good as it gets.
Matt, excuse me, well done. Good presentation. What's the political buy-in? I mean, what you're doing is pretty advanced, but we know in current political climates. Have you got any feedback on the work from politically motivated people?
No, is the easy answer for that one. Obviously, they're quite keen to meet the requirements for being able to publish this kind of material. I think really it's how local councils, infrastructure planning and things pick it up, but also insurance is probably one of the biggest sectors that probably have the most leverage to make people listen, because everyone's answers to the insurance of their business or homes or otherwise.
They are talking in places, American and Canadian, that there's going to be places that just you're not going to be able to get insurance for your homes. Some of the areas that are getting projected. Is that a likely scenario as well for New Zealand, based on climate change?
I don't think I can comment on that.
Right. Okay. I guess that's extremely political as well. All right.
Yeah. Yep. I think the whole world's heading that way, though, isn't it?
It certainly is an increasing issue that's being discussed, Chris. Is that councils are letting people build in certain areas, but potentially letting them build in certain areas, but they can't get insurance. So certainly where we are, the council has allowed people to build near the foreshore, but whether they get insurance or the insurance is too costly for them to allow to go ahead, that's becoming the issue. So in fact, I think that the insurance councils are going to be the greatest determinant of where people build, in future. Because you're not going to be able to get insurance and you're not going to be able to get a loan. So that's it.
Yeah, I mean, it's been a while since I've lived in New Zealand, but one of the major problems we have in the UK with housing and health is the mold growth, particularly in private properties. And if you're going to get wetter and warmer, then you're going to have more mold growth, aren't you? I mean, this is a huge problem for renters and for the insurance that they purchase in that regard, or the owners purchase anyway. Interesting. Okay.
Might I suggest we plug the Mentimeter again, or even better,
Sure.
share it. Screens. Excuse the clutter.
I mean, one of the things, if we're talking about everything, I think that for the years I've been involved in health surveillance, the thing that's always held up as the pinnacle of how you do it is the Scandinavian countries. And I think that they seem to have an incredibly integrated and well thought out process by which they're able to do work that in many instances New Zealand we actually just dream about.
Yeah, I mean, they're basically birth till death geolocation, right? They've got an address for where you've lived your entire life if you stayed in the country. I mean, exposure estimation doesn't get any better than that.
And I think having one agency, Chris, actually helps with a mandate.
Yeah, and I guess somebody's mentioned that here, right? Integration of agencies, integrated data capture, integration of systems.
Incidentally, I would very much like to know who put Chris's name in as something missing from New Zealand's health surveillance network.
Despite it being true, who would do that?
We always knew that.
Trained staff.
The other thing I thought was good that came out of Esther's presentation was how she said that the group that she's working in is about the early detection for prevention and action. In many instances, surveillance is just a thing like you draw a graph, you do some analysis, and that's fine. But I think WHO's definition is some action and prevention of something getting bigger. And I think there's an important definition for us to think about.
I don't think any of us have a particularly good track record on actually acting on forecasts, do we? I mean, the climate forecasts made in the 1980s at the very first Woods Hole meeting pretty much held true. So we've known for a very long time where we were heading, and we did nothing about it. But that's true in health as well. How long did we have Campylobacter surveillance before you guys actually intervened and made a big difference? I mean, that was a long time.
It's interesting leadership.
Yeah.
Who should lead the surveillance activities in New Zealand?
Well, if I don't mind me showing this second slide, it's a little more interactive. So the purpose of this part of the Mentimeter is to get you to fund your dream health system. And what you'll see on my screen is the average of everyone else's results.
Ah, okay. That's interesting. I'm not happy about the whole aged care being on the bottom of the pile, just saying.
Environmental and occupational, it's actually very interesting that because the thing that grabs people's attention immediately is infectious disease surveillance. That's the thing everybody gets really upset and jumps up and down about. But if people think you need to spend more money on occupational environmental, that's an ongoing problem rather than an acute problem like infectious disease surveillance.
We've already forgotten about the pandemic. That's history. Never happened again. We've got 100 years, right?
Yep. So don't worry about that now.
Yeah. Mental health services is a really interesting one, isn't it? I mean, do we have anybody here who's doing surveillance in mental health issues? I mean, it's a tricky one, isn't it?
The other thing that I'd be interested to know how people react to, I mean, probably comes under staffing and wages, but actually training. I mean, one of the big issues we've found constantly comes up when we talk about PHONZ is how do we train people in public health intelligence or health intelligence? Or who does it?
Indeed. Do you think everybody's talked out at this point, Barry?
I think so. We'll probably move on.
Have a 5-minute break before your next one starts?
Yes, I think so.
Okay, so you got basically 6 minutes.
So we'll be reconvening, ladies and gentlemen, at 10:51 when Dr. Jefferies will be kicking off.
Great.
Thanks for having me.
Well, thanks, Matt. And thank you, Andre and Lewis.
Lights, camera, action. Patrick, you need to say that, I think. Morning, everyone. My name's Tim. I'll be taking over the chairing responsibilities from Chris for the rest of today's session. And our next speaker is Dr. Sarah Jefferies, who joins us from the newly named New Zealand Institute for Public Health and Forensic Science, formerly known as ESR. Sarah specialises in national communicable disease surveillance and outbreak responses. Sarah provides public health strategy and technical advice on behalf of the Public Health Agency, including on national and international surveillance, planning, risk assessments, intelligence and responses. Sarah has experience working in surveillance and outbreak response throughout the Pacific region, as well as supporting various regional and international pathogen genomic surveillance development initiatives. Welcome, Sarah. The floor is all yours.
Thank you, Tim. Kia ora koutou katoa. Hello, everybody. Thanks so much for having me here today. It's been really great to see the presentations from around the world at the conference. I'm going to be talking about pathogen genomic surveillance, which is about how we are increasingly using advanced technologies like whole genome sequencing that allow us to read and compare the genetic codes of pathogens, which are causing human, animal, and plant infections and living in our environments. We integrate that information with other important sources of information from the surveillance systems to better understand trends in diseases and their causes. And ultimately, this is so that we can support public health decision-making and better prevention and control of infectious diseases. So today I'm going to be giving an overview of the pathogens we have under genomic surveillance at PHF Science. Then I'm going to describe the roles of pathogen genomic surveillance in a public health response from a One Health perspective. And the example I'm sharing is a national response to an outbreak of acute gastroenteritis caused by a Vibrio bacteria. And I'll describe the use of pathogen genomics in the One Health investigations and the public health impacts that resulted from this response. I'd also like to acknowledge our multidisciplinary team and partners involved in the applied pathogen genomics work that we do. So these are some of the friendly faces of some of our PHF Science National Multidisciplinary Outbreak Response team and those most involved in the response that I'm speaking to today, but there were also many others involved. And there are some very important national and international partners. We provide national and international infectious disease surveillance, public health laboratory and outbreak response services on behalf of the Public Health Agency and the Ministry for Primary Industries and others. The Ministry for Primary Industries, of course, is our Biosecurity, Animal Health and Food Safety Authority. And we even co-share a location with our National Animal Health Laboratory in Wellington. We also work closely with Health New Zealand, our national and local public health colleagues. And we've been working, of course, as well for a long time, as has been mentioned, with the Pacific Public Health Surveillance Network. And Mark Jacobs was introducing some of those activities yesterday in the session, which was great to see. We, of course, work closely with the WHO and we support regional and global pathogen genomic initiatives like the IPSN. So that's the International Pathogen Surveillance Network. And those are initiatives that are really important to using applied pathogen genomic surveillance as a really critical tool in the prevention, preparedness and response to epidemic and pandemic infectious disease threats. This is a summary of the infectious pathogens which we currently have under routine surveillance. In New Zealand, we started in 2018 with routine sequencing of Listeria, Neisseria meningitidis bacteria, and CPE, and that expanded to include various other pathogens and most recently Yersinia species. But we sequenced other pathogens for various reasons, for example, outbreak investigations in community and healthcare settings. To support research, we have private industry requests and also international requests as well. The graph on the right summarises the species that we sequenced in 2024 through health funding, but we've excluded SARS-CoV-2, and this has been kindly produced by our genomics lead, David Winter, who always likes to point out the red bar on the chart, which represent quality control sequencing that we do. So quality assurance is a really critical aspect of any public health surveillance system. Hopefully, many of you are familiar with One Health as a concept and way of working, and it's widely recognised as critical for global health security. It recognised the interconnections between the health of humans, animals and our environments, and the importance of well-integrated cross-disciplinary action to prevent, prepare for and respond to infectious diseases. Pathogen genomic sequencing is a tool which identifies a common language in the pathogen genome as pathogens spread and evolve within and between people, animals and environments. We can now better monitor, investigate and understand them. So we have found pathogen genomic sequencing has helped us answer a variety of important questions. One of them is what is infecting our people, our animals, and our environments. We can much better characterize pathogens, being able to discriminate and compare them at such a fine degree as their genetic codes allows us to more finely and quickly identify unusual trends and help us to detect outbreaks more early. And it also helps us monitor and understand the pathogens that are emerging, such as the arrival of a new strain, which our communities may not have an immune protective response against. And it can also detect features of virulence, such as antimicrobial resistance that's coded into the genome. We also use it to better understand who is affected by a particular infection, to better define who is involved in an outbreak and allow us to target interventions to hone in on the cause. So it allows us to improve the quality of the epidemiological investigation to identify a common source, for example. And it contributes to finding out why an outbreak occurred, understanding for example, what the molecular evolution of specific pathogens are, how their genetic codes are changing over time, place, and between people, and which is also really critical to be informed by the epidemiology and other sources of information, can reveal transmission dynamics and help us better target public health interventions. We also share the genetic data of pathogens with colleagues overseas, connecting public health knowledge and resources for a much wider public health impact internationally. So I'm going to outline one of the responses which has really contributed to building our working relationships in the area of pathogen genomics with our animal and environmental health colleagues. And this was during the start of a series of outbreaks, initially due to shellfish poisoning in 2019. Here's a map of New Zealand on the left. We are, of course, an island nation, and seafood is a really important part of our society. The red circles show our major mussel and oyster growing areas in both of our North and South Islands, which contribute to New Zealand's blue economy, but it's also a very important local food source to many communities. Our kaimoana has great cultural importance to Indigenous Maori, and the New Zealand greenlit mussels are also promoted occasionally as a health food. So Vibrio parahemolyticus is a saltwater marine dwelling bacteria. It multiplies in warmer waters and is of concern as a climate sensitive organism with increasing prevalence anticipated because of climate change. It can concentrate in bivalve molluscan shellfish, which filter feed from the water. If these shellfish are eaten raw or undercooked, the bacteria can cause an acute gastroenteric illness quite quickly, and occasionally can cause a severe illness which requires hospitalization. It is the most commonly reported cause of bacterial seafood poisoning in the world, and previous outbreak-prone regions were the USA, China, Japan, and Spain, and large outbreaks were actually really very rarely reported in the Pacific region. And so I'll take us through the role of pathogen genomic sequencing in this outbreak investigation, firstly starting with the human health response in May and June of 2019, when we detected an unusual increase in the number of cases of Vibrio parahemolyticus acute gastroenteritis notified to the National Notifiable Disease Database, EpiServe, which we manage here at PHF Science. The initial information we had was based on the routine investigations by local public health teams, and that involved local testing to detect the presence of the Vibrio bacteria if suspected to be causing infection, and referral of positive specimens to us at ESR at the time, as we were previously named, and for further testing, and then local epidemiological investigations, which was an initial case interview by the public health teams. Our routine typing at ESR for this pathogen at the time was limited, so we recommended whole genome sequencing to investigate the outbreak, and we sought funding from the Ministry for Primary Industries. We explained that this would help identify if this was due to an emerging strain. It could help us identify factors of virulence and also relatedness between the cases to help us understand transmission dynamics of how infection was occurring and direct further investigation. So funding for some limited sampling was approved at that time. And so the sequencing of the outbreak isolates identified it as a pandemic clone of Vibrio parahemolyticus, sequence type ST36. In this paper in 2020 by Abanto and colleagues, they describe the spread of this pathogen strain associated with increasing outbreaks overseas, starting in the coastal USA. The strain spread through the coastlines of North America, down to South America, and made its way over to northern Spain. And so we compared the New Zealand outbreak strain of ST36 to the genome sequences which the researchers had kindly made publicly available from this study. And it was really helpful that the data were already available to help us with our own response in New Zealand. And this figure on the left shows the results of that analysis. It shows groupings of this pathogen by their genetic relatedness, originating in the USA, shown in purple, Spain highlighted in green, both the coastlines of the USA, and now spread into the Pacific region, detected for the first time in New Zealand, highlighted in red. So we used the identification of this strain to identify outbreak cases infected with ST36 to target more detailed case interviews, and this found that cases had eaten commercially supplied mussels bought from supermarkets and local shops. The environmental investigations then expanded, and the Ministry for Primary Industries conducted traceback investigations from the point of purchase to the source. They excluded incorrect handling of the mussels by the shops or the cases and traced the mussels back to one mussel bed. They immediately looked for water temperature monitoring records by the mussel supplier. And then they immediately paused the collection of mussels from that bed to stop them entering the food chain. Mussel samples were then taken for testing to see if the outbreak strain could be detected. And this led to a lot of sharing of information with our clinical and external plant and food laboratory colleagues as well. So this graph shows the epidemic curve of the cases infected with Vibrio parahemolyticus detected in New Zealand between January 2019 and May 2022. The colours on the graph show the sequence types, these were the strains that were infecting the cases. And you can see on this graph that we had 4 major outbreaks over this time. If we look at the first outbreak peak on the left, this is the 2019 outbreak, and I'd like to point out 3 things about this outbreak. Firstly, you'll notice a high proportion of cases are coloured purple, and that means their pathogens were not sequenced. So this is because we had limited funding to apply at the time. So we had to do representative sampling among the cases across person, place, and time characteristics, and also had a limited number of background isolates from cases prior to this outbreak so we could compare what we usually would see in New Zealand. So despite the limitations, we felt this was a robust representation of the outbreak cases to inform the response. Secondly, I'd like to point out the timing of this outbreak. So this was in winter in New Zealand, when we would expect water temperatures to be lower. And we know that this pathogen tends to go in warmer waters. So had there been an abnormal water temperature event in this mussel growing area, or did this represent a more virulent strain, or was it a combination of factors? So further information and research was needed in the New Zealand context. And lastly, I'd like to recognise that although we had 23 outbreak cases in this initial outbreak, we recognise that the true scale of the outbreak was likely to be much greater due to case under-detection. So the impact of an effective public health response was likely to reach far wider than we could accurately measure. Among all of these outbreaks, nearly 50% of cases were among Maori, and so it was also very important to address this big inequitable health impact too. And so to describe some of the public health actions and impacts that stemmed from this response, we identified obviously a new pathogenic strain in New Zealand in 2019, and we helped identify and control the animal food source. We raised awareness with Food Health Authority decision makers of the raw undercooked mussels as an increasing risk, and that led to animal environmental monitoring being put in place and funding for further research to investigate this pathogen. It led to a change in the regulation of commercial shellfish growing areas requiring Vibrio management plans. It led to improved communication campaigns to promote community health, including videos of how to safely prepare mussels. And the response also strengthened our working relationships between human, environmental, and animal health, with leading to greater investment in pathogen genomic surveillance, and also agreements to share data internationally to promote much broader impact as well. These are some of the surveillance changes I was going to touch on. I wanted to point out that you can see the colour of the major strains that we detected changed over time to a blue colour. So we had found that it shifted from ST36 to ST50, and also that there was a broader dispersal of around New Zealand geographically where cases were emerging, and also in the types of shellfish that were being affected. And so sequencing was really important to deploy to be able to continue to discern this strain and the different sequences that were mostly affecting locally as well, and to support further investigation. We also had improvements in other parts of our surveillance system with more complete referrals of specimens from local labs to the National Centre for Sequencing. And some of the further research that has started has also been very important as well. So one of the projects underway as a result of these outbreaks of investigations is looking to take the monitoring of this pathogen closer to local communities, and it was set up by ESR's Maori, or PHF Sciences Maori Impact Team, and it's been led by our colleagues George Bell and Vinko Besic. They are developing a point of need test with local communities to see if one day our communities can sample their local waters themselves to detect these pathogens, to tell whether it's safe to collect shellfish or not. And so to wrap up, we know there are increasing global pressures on our human, animal, and environmental health with rapidly changing ecosystems, climate change, urbanisation, population growth, increased travel and trade, fragile public health systems. We expect epidemics can become more frequent, more complex, and difficult to prevent and contain. So pathogenic surveillance is a tool which we can apply across our disciplines, working together to better tackle these challenges within our communities, countries, and internationally. And I'll finish now, just skip on to the acknowledgements to thank the many people involved in this work. Kia ora, thank you.
Thank you so much, Sarah. That was really interesting to see. I don't think I've ever seen it in such a sort of a way that you've included all 4 outbreaks. So yeah, it's really interesting to see. Thank you. We'll open the floor for a few questions. If there's any, feel free to put them in the chat. It was nice that you mentioned One Health, Sarah. In New Zealand, I think that's something that's quite difficult to achieve just purely because of the number of agencies responsible, because you've got to include things like MPI, Ministry for Primary Industries, obviously health, and people like the Ministry for Environment. Do you see that as a bit of a barrier in achieving a better response to One Health issues?
No, I don't think it's a barrier. I think it's a strength that we have so many experts in different agencies, and there's multiple ways that different agencies and different groups of researchers and scientists who are working in all of these related areas are already linking. We have One Health Aotearoa, we have the Taneefa Infectious Diseases Research Platform in terms of taking a research approach to these overlapping issues. And we have plans are coming into place, such as the National Health Climate Adaptation Plan. So certainly a lot of levers for us to be working more closely together. But there are always ways that we can build upon those existing relationships and get to a better and better place. And that's what's needed with these increasingly complex public health challenges that we have to address. So yeah, thanks for the question.
Very much. And do you see, you mentioned under detection, do you see that as potentially a big issue as well?
Yeah, it is a really difficult one. Acute gastroenteritis particularly is notoriously under-detected. There's so many barriers to getting a diagnostic test that will identify the cause of that very common illness. People may not be able to get in to see a GP. If they do get in to see a GP, they then have to provide a specimen, and then once the specimen is received by the laboratory, it then has to meet criteria for testing. And unfortunately, we do see a disproportionate proportion of cases identified because they've been admitted to a hospital. And so that there's definitely a severity bias in the notifiable data that we see for Vibrio paralyticus acute gastroenteritis, but also other acute gastroenteritis sources of infection. So yes, massively detected illness, but it has been fortunate that there were signals certainly enough to make us investigate and identify and for multiple responses to happen to start to prevent the source. And certainly numbers have dropped down to baseline levels since 2022 and the number of actions that have happened.
Nice. Thanks, Sarah. And I see Barry's got a question.
Hi, Sarah. Well done. Thank you.
Hey, Barry.
Just picking up what Tim said about One Health, for a long time when I was involved in some aspects of that, it was very much driven by the vets, and health sort of played a tag-along role. In your experience now with this particular issue, is the health people actually getting, putting more emphasis onto the One Health focus, or has it changed?
I think it absolutely is. There is a huge health focus. It's appearing in a lot of our international, regional, and national health plans as a really important aspect of how we prevent pandemics and prevent inequities in infectious diseases. It's recognised in the pandemic agreement, in all sorts of levels of strategic and operational health documents. We have meetings regularly now with other agencies across from health, so that we can have more situational awareness and have closer working relationships. So these multidisciplinary approaches are definitely happening, and I think health is certainly supportive and leading that as well.
Good to hear. There's a couple of questions in the chat. Question asked for you, Sarah.
Great presentation, Sarah. What did temperature monitoring tell us in the context of these outbreaks?
Thanks, great question. So in 2020, I think New Zealand Plant and Food supported with MPI and the local growing areas had some temperature monitoring. In 2020, I think it was another winter outbreak, and there was certainly above the temperature that is required for proliferation. What happened after that was that we had those more typical summer-based outbreaks, particularly late 2021, 2022, and that was actually at the time the 5th highest temperature summer on record, with sea surface temperatures averaging over 5 degrees, what would normally be seen at that time of year. So, it's likely there's multiple factors involved, pathogen-specific factors, and certainly environmental factors that are contributing to these events. But yeah, more research is always required, and certainly temperature monitoring is an important part of the ongoing surveillance now.
Yeah, thanks, Sarah. And last question, can we check with you about Aotearoa's role here? Aotearoa, with the Drinking Water Authority responsible for drinking water. Do they have a role?
So not in this case, because it's based on seawater, so not our drinking water supply. So not in this instance, no.
Maybe more so MPI though, being a food.
Yeah, MPI were very, very closely involved. Yeah, absolutely, and led a lot of this as well.
Nice. Well, thank you so much, Sarah. That was wonderful to hear from you.
Great. Thanks so much. Bye-bye.
Our next speaker, Dr. Andrew Anglemeyer, joins us also from the Institute for Public Health Forensic Science, formerly known as ESR. Andrew is an epidemiologist who specializes in infectious diseases and study design methodology, a research associate professor at University of Otago, previously University of California at the San Francisco campus. Andrew was a member of the World Health Organization's HIV Treatment Guidelines Development Committee and the epidemiological editor of the Cochrane Review. Andrew has published 80 papers covering a wide range of public health and clinical topics, including HIV prevention, treatment in high-risk populations, firearm-related injuries, and a few other things as well. Andrew is a veteran, having served in the US Army from 1996 to 2001 before undertaking his studies. Welcome, Andrew. It's nice to have you here. Your presentation theme, invasive pneumococcal disease in New Zealand, impact on a changing childhood vaccine schedule. Very interesting. The floor is all yours.
Thank you. Hi. So I'm Andy Anglemeyer, and I'm also just returning from holiday. I've been gone for about 3 weeks, and I was overseas, and I'm still wearing the ESR hat, even though I now have a new name. So apologies if I refer to my former organization as ESR, my current organization as its formal name, former name, I should say. So I also am still getting used to it. And I also have an Otago hat that but about 5 or 10% of my time, depending on the situation, and as within the Department of Preventative and Social Medicine in Dunedin. So, yeah, so I'm going to talk about invasive pneumococcal disease. I've been working in this space for about 5 years now at ESR. It was once known as ESR. And I've seen a lot of changes in those 5 years. And up until this point, most of my talks have been about sort of like bringing the bad news, if you will. But this might be my first over the years that have actually got sort of bringing the good news. And I mean, there are elements that still obviously could improve, but nevertheless, the overall message is that we have at least turned the corner, it seems. So acknowledging our team, we have Julie Morgan in our lab, and we also have Charlotte, who's a fellow epidemiologist, and Andrea McNeil, who's our epi lead, and Hannah Cooper, you'll see her in a minute, who's our public health physician, with this in her portfolio, and Uniren, who's in our technical lead in invasive pathogens. Today, I'm going to cover trends in invasive pneumococcal disease by age, ethnicity, specifically looking at different types of different serotypes. And then really the crux of the talk will be really how much impact did we have with changing our vaccine schedule for children at the end of 2022. And also just looking forward to the future and sort of taking a sort of a proactive approach about the future and our surveillance for IPD. So Streptococcus pneumoniae causes significant worldwide morbidity, about 5.8 million deaths in 2015, according to WHO, and children under 5. So obviously a pretty significant risk with regards to illness and death. And there are vaccines that have been developed to prevent that illness. These vaccines for New Zealand, at least, were introduced in late 2008, around October, November 2008. So the vaccines cover only certain serotypes, and the goal of the vaccines is to cover serotypes that are responsible for the bulk of disease. Okay, so PCV7, or pneumococcal conjugate vaccine, covering 7 serotypes, was introduced in New Zealand, like I said, in 2008. But then we introduced PCV10, which covered 10 serotypes in 2011, and 2014 PCV13, and in 2017 we went back to PCV10, and in 2020 we stayed with PCV10 but reduced the number of dosing from 3 + 1 booster at 12 months to just 2 doses with a booster at 12 months. And then in 2022 we went back to PCV13. So a lot of whiplash in our vaccine schedule in our national immunization program with regards to PCV. Only a couple of countries worldwide have actually gone from PCV 13 back to PCV 10. 3 countries previously have done it. And all 3 countries now are back with PCV 13, including New Zealand. So to give you some context of what these vaccines cover, so the PCV 7 covered 7 serotypes, PCV 10 made by another manufacturer covered those 7 serotypes plus an additional 3, which was 1, 5, and 7F. And then PCV 13 covered those 10 serotypes plus an additional 3, including 3, 6A, and 19A. And you sort of get the routine from here. So PCV 20 now is now available in some parts of the world, namely in the US. PCV 20 is, and PCV 15 for that matter, is now part of the childhood vaccination schedule as of 2022, 2023, something like that. Yeah, and PCV 20 covers those 10 serotypes you'd find in PCV 10 plus an additional 10 serotypes. So obviously, covering more serotypes is good. Just of note, one thing to point out is that because not all vaccines are made the same in terms of their sort of effectiveness covering certain serotypes. So, for example, I'm just using this as an example, not with any evidence, but say you can see PCV 7 covers 23F, but so does PCV 10, but they might not cover as well as each other, 2 different vaccines. And so even though they do have coverage, it might be still some breakthrough cases of 23F in PCV 10 vaccinated kids. Just pointing out that not all vaccines are made the same. There was some speculation that PCV 10 would offer some protection against serotype 19A. This was based on some manufacturer data, and that this was due to some cross-reactivity from 19F, which is in fact contained in PCV 10. But with our own data and also from international sort of observational data, we know that there's actually pretty little evidence to actually suggest that PCV 10 does offer any protection against 19A. So in 2022, you can see this huge spike in 2022, and that blue line there is children under 2. And that was our highest rate we'd seen for children under 2 for pneumococcal disease. In fact, we're unaware of any country with a national immunization program that had a higher rate of pneumococcal disease for children under 2 in 2022. So we were uncharted territory. And that rate for children under 2 had been increasing for several years, namely from 2020. And once we reintroduced PCV 13 at December of 2022, we can of course now see this big drop, which is really good to see. The power of the appropriate vaccine for our current epidemiology. But we also saw that drop in children 2 to 4. So 2 to 4 would be the orange line. Sort of, if you look at, yeah, you can see the orange line there. It's now the 4th highest rate, if you will. So that also decreased. And the adults 50 to 64 and 65 and over, however, has increased since 2022. And the idea here is that they're indirectly protected, right? So the vaccine is available for children as part of their vaccination program, but not offered. The PCV vaccines are not offered for adults in New Zealand, so, or at least not funded. So they're only benefiting from indirect protection from passive immunity from the children. So it'll take a little bit of time, and I'll show you some slides on that too, but it'll be a little more time before we'll start to see adults and their rates of pneumococcal disease start to go down. But the effects we're seeing for adults, in other words, the high rates for IPD for adults, especially for the 65 and over, it is nearly the highest we've seen for adults 65 and over, but not in 2024. That's not terribly unexpected considering in 2022, we had nearly the highest rates, or they were the highest rates we'd seen for children under 2. So because of that delayed immunity, I think safe to say that we're hoping and expecting those rates to come down in the older adults here shortly. So in 2024, we see our highest rates in 65 and over. But this sort of U-shape in incidence rates by age group is commonplace for a number of invasive infectious diseases, as we know. But this is kind of what we'd expect with IPD in most countries, sort of the highest among the oldest and the youngest. So, but the good thing here is that the children under 2, once again, that rate, and that we saw in 2024, is lower now than adults 65 and over. So that's the first time we've had it lower than 65 and over in nearly 5 years. So the impact, the direct impact of the vaccines is pretty obvious. Now, if we shift gears to looking at trends by ethnicity, we can see that unfortunately the rates for pneumococcal disease, invasive pneumococcal disease, are the highest among Pacific and for Maori as well, and that has been the case since, well, at least for the last 10 years. Rates for Pacific peoples increased in 2024 and 2023, but did actually drop in the last 2 years for Maori. So that's good. And then for Asian, and also slightly for Europeans, they did drop as well. And if we look at the relative differences between, say, Maori or Pacific versus European ethnicity, we can see that the rates are traditionally, if you will, over the time, have been anywhere from 3 to 5 times higher among Maori compared to European for the last 10 years. And for Pacific, it's been anywhere from 5 to 6 times higher. So we haven't seen a big change in that trend yet. In fact, if we look at the IPD rates by ethnicity, specifically within age groups, we can see that the Pacific and Maori have the highest rates for across most age groups, especially the older and the younger age groups. So it's not really one age group or one age group or one ethnicity that's really driving those rates. In the interest of time, I'll skip this. And when we look at NZ-DEP, specifically looking at Maori and Pacific, we can see that Pacific, regardless of their NZ-DEP quintile, had the higher rates of IPD than nearly all quintiles of NZ-DEP for all ethnicities. So we can see there's a huge burden of disease across all Pacific, not just the highest or lowest quintiles of NZ-DEP. Okay, so the drivers of disease over time have, at least especially the last 5 years, have been this one specific serotype called 19A. Now, this 19A serotype is contained in PCV13 vaccine, or at least covered by PCV13, but not PCV10. And so that's really the biggest driver of our disease, especially of the rates for the children under 2, was this 19A. So the good thing is, across all age groups, 19A has in fact dropped, which is really, really good news. We have also other serotypes that are responsible for, serotype 8 here in 2024. We see as a high numbers now, almost, I think 18% of our total cases were serotype 8. So these are other serotypes that we need to keep be aware of as moving forward with regards to our immunization program. In the interest of time, I'll skip this as well. So this is just looking at our incident cases of IPD in children under 2 and 2 to 4 from 2017 to 2022. This is all pre-change in vaccines. And you can see the red line here is the total IPD cases, and it's obviously increasing dramatically from 2020 through 2022. And the green line is IPD due to specific PCV13 cases. So in other words, what proportion of our total IPD was due to a serotype that was contained in PCV13. And we can see it follows pretty well along the total IPD cases. So pretty remarkable increase. But we introduced in 2022 this PCV13. Yet again, in the blue here is sort of my washout period. That's the PCV13 rollout. And then in the red square or rectangle, we can see our 2 annual rates, or in this case, there's a number of cases of IPD since that rollout, and we can see it dropping down quite a bit. So that's all really, really, really good. This is exactly what we were hoping for, especially in the children under 2 and 2 to 4. So kind of reassuring us that PCV13 change was exactly what we needed to have happen. And if we can make a comparison between 2022, which was a sort of the last year of PCV10's era, and 2024, which would be the second year of the PCV13 era, we can see that the incidence rate ratios had dropped across essentially all subgroups for children under 5, across all subgroups, ethnicity, age, and sex, by around 50%. So huge drops. And what's important here, though, is that the only subgroup that actually did not decrease significantly was the rates for IPD and children under 5 who are Pacifica. We don't see a significant drop in there. In fact, for going back to this page, sorry, 1 second. Going back to this slide here, for children under 2 in 2024, we had 26 cases of pneumococcal disease. Just keeping in mind, I should probably mention all these cases are hospitalized. These are all very, very, very sick individuals. So having 26 cases in children under 2 is still quite a big burden, even though it's less than it has been in the last few years. But 21 of them were Maori or Pacific. So huge disparity for children under 2 relative to European others for Maori and Pacific. So we have this massive drop on the left under 5s, this big drop in PCV13 specific incidence for children. And then on the right, we have the 65 and over. Now, even though we have a small decrease, not like the big decrease we saw on children under 5, we have a small decrease seen in 65 and over. I think our expectation is that will actually be much lower this year as a result of indirect and delayed immunity from children being vaccinated with PCV13 at the end of starting in 2022. And looking forward, we can talk about PCV13 serotypes and how they are still occurring at high rates, at least for adults, because they're actually not directly protected with vaccines. However, PCV20 serotypes, the 20 serotypes contained in PCV20, actually accounted for nearly 70% of our total amount of IPD. So looking forward, we could even think about proactively, perhaps that's what's around the corner. Vaccine that's being used overseas could potentially be used here and potentially cover up to 70% of our total cases. And all that is to say is that PCV10 is doing a really, really good job at preventing the PCV10 serotypes, but not so good at preventing any other. PCV13, the same, but we also have this avenue for this opportunity for preventing all of these a number of other cases that were contained in PCV20. In summary, IPD, pneumococcal disease, invasive pneumococcal disease for children under 2 and 2 to 4 have significantly dropped across the board, which is really, really good. Unfortunately, still quite high for Pacifica and Maori for children under 2 relative to other ethnicities. And for 65 and over, while they're still really, really high, and actually nearly the highest, if not the highest we've had since PCV was introduced in 2009, we expect that rate will actually drop here in the very near future due to indirect protection. And with that, I have opened up to questions.
Thank you very much, Andrew. That was a wonderful presentation. Very thought-provoking. I'm sure there's a few questions. In fact, we have one here from Phil Schumack. Hi, Andy. Has anyone done a cost-benefit analysis of analysts that would support extending eligibility to PCV13 to older age groups and to Māori and Pacific of all ages. Waiting for older age groups to benefit from vaccine coverage of children feels rather passive and risky.
Yeah, that's an excellent question. So I think the time is ripe for that investigation to happen now. To answer that, it has been on my radar, and I have actually proposed that very question, but getting the team together that would be able to have the skill set to do that yet has not happened.
Right. Thank you. I have a question, Andrew. When are we likely to see PCV20 in New Zealand?
Yeah, I actually don't know. I know actually that there are a number of people who are quite interested in that very question, and so the answer to the question, I don't know, but I have if I were a betting man, I would think we would see it in the near future, meaning in the next 5 years. But that's actually pretty good. I'm just throwing out a number. And the reason why I say that I'm hoping that that's going to be the case is that I know that there is an interest in funding changes for Pharmac, and also by that time, PCV20 would have already been used overseas for 8 to 10 years, and so it would fit in line with how things have been going.
Nice. And is there, you mentioned funding, is there a significant cost difference between the different?
I don't know. I don't know. Those are questions well beyond my pay grade.
No, one more question. Is there evidence of less severe hospitalized cases in parents far now? Could they be targets of vaccination?
So non-hospital, so like otitis media or something along those lines. So yeah, I don't have any, because our surveillance system is actually focused specifically on the invasive pneumococcal disease. Those are all very, very sick individuals, so they're going to be hospitalized. There is ongoing research on say the non-hospitalized cases, like say otitis media and so on, but I don't have any evidence for that personally, and I don't know where we're at with that. The problem we have, and it's a bigger problem, it's not damning, but it makes it more complicated for research purposes, is that we've had such whiplash with our immunization program that we've had, say, 3 years with PCV7, and then 3 years with PCV10, and then 3 years with PCV13, and then 3 years again with PCV10. But that's not really clean cohorts, because if you're born in, say, November of 1 year, and then by the time you get 6 months, you're also now in another era of another vaccine. So you've actually might have had 2 different vaccines. So, and also the cohort of children under 5, that's going to include a sort of a hodgepodge of people who are given PCV10 or PCV13. So it makes it very, very difficult to isolate who's actually received what on a population level. So that's when it gets really complicated.
Okay, this is definitely the last question, Andrew. It's from Tom. Good presentation. Could we have a similar monitoring to PCV20 non-PCV13 stereotypes as we did for 19A stereotype?
For stereotypes, yeah. No, yes, Tom, it's ongoing, and we have already been, even just this last month or so, we did some internal document looking at specifically those serotypes. Yes.
Great answer. Thank you very much again, Andy. It was a wonderful presentation. Some good discussions there, and yeah, thank you very much.
Yeah.
It's a nice segue into our next presentation, Dr. Hannah Cooper, who also joins us from the Institute for Public Health Forensic Science. I'm still getting used to that. Hannah, previously known as ESR. Hannah leads the Vaccine Preventable Disease Surveillance Portfolio. Hannah is also a fellow of the New Zealand College of Public Health Medicine. Welcome, Hannah. It's lovely to see you. I will hand it over to you.
Kia ora. Let me just make sure I can do the slide thing appropriately. All right, is that sharing?
We see your whole PowerPoint presentation, including all the slides down the side.
Sure. Has it gone now to the... Let's say stop sharing. Sorry, should have practiced this beforehand. I'll just try that again. Share window. So much more familiar with Teams.
Yes.
It looks like when I change it to full screen, it's not going to show in the...
So Hannah, have you started playing your slideshow now?
If I play it, then I can't access back to the... I have started sharing it, but while it's being shared, I can't go into the conference to share.
If you want, you can use the current way. Maybe if you can make it a bit bigger.
Yeah, okay. Apologies for this slight hiccup.
Yes.
Get rid of that as well. And is that going to be a working solution?
We can fix it.
Well, apologies everyone, and kia ora koutou. As Tim introduced, I'm Hannah Cooper, also at PHF Science. We've got a little blockbuster of us in a row. Thanks Sarah and Andy for those presentations. My talk this morning is on the epidemiology of invasive meningococcal disease in New Zealand, also looking at the impact of vaccines, so seeing what's happened since Bexsero was added to the childhood schedule in March of 2023. This is going to be a bit clunky, sorry, so I click through. I don't have pretty pictures, but I also would like to acknowledge the wider team and others involved in the whole system of meningococcal surveillance in New Zealand, and particularly Lisa Lopez and Giles Graham, who prepared the analyses that I'll be sharing today. But also want to acknowledge that, like IPD, meningococcal disease is a very severe illness, and all these numbers I'm presenting today are real people and affected whānau, so wanting just to acknowledge them as well. This is the brief outline of my talk, and in the interest of time, I'll just crack straight into it. So many of you will be very familiar with meningococcal disease, but just some brief background for those who aren't. It describes invasive infection with Neisseria meningitidis, which is a gram-negative diplococci, pictured on the right there, and it can be a very serious disease, typically presenting non-specifically, but then progressing rapidly and can be fatal even with timely antibiotic treatment. Asymptomatic carriage of Neisseria meningitidis is fairly common, with estimates around sort of 5 to 15% of the population, particularly peaks in adolescence and contributes to the higher risk of meningococcal disease in this age group. And Neisseria meningitidis is spread via the respiratory route, usually requiring quite prolonged close contact. And why some people can carry the harmless bacteria, whereas others develop severe invasive disease, isn't completely understood. The surveillance system for meningococcal disease, like other notifiable diseases, involves cases being notified to a medical officer of health, who investigate and undertake the public health response and collect the information that's reported into our surveillance system that we can then summarise, like I am today. A confirmed case requires detection of Neisseria meningitidis in CSF blood or another sterile site. And sometimes if lab confirmation is not possible, cases can be notified as probable if they have a clinically compatible illness, and meningococcal disease is thought to be what's responsible for it. Clinical samples and cultured isolates are sent to PHF Science to our reference meningococcal lab for characterization. And since 2024, so last year, the group and pore type are able to be determined through genomic analysis. And if we have a cultured isolate available, that will undergo whole genome sequencing to get even more information on this strain. Before going into more detail about recent history, I just wanted to present this slide showing a longer term trends of meningococcal disease in New Zealand. And as many of you will remember, there was a large prolonged outbreak of Group B in New Zealand throughout the 1990s into the early 2000s. It was ultimately brought under control by a strain-specific men's B vaccine. And so incidence since 2007 has been substantially lower than it was prior, but still remains fairly high compared to some of our peer countries. Just some brief background on the meningococcal vaccines available. There are two broad classes, those against groups A, C, W, and Y, which are polysaccharide capsule conjugate vaccines. These are provided as a quadrivalent vaccine in most countries, including in New Zealand, and they protect against disease caused by those group ACWY strains, and also for some of the groups do reduce carriage and can achieve a degree of herd protection amongst people who aren't receiving direct protection from vaccination themselves. On the other hand, Group B vaccines have been more difficult to develop a universal Group B vaccine because the polysaccharide capsule in Group B is quite similar to antigens found in humans, and so it's poorly immunogenic. As noted, there have been strain-specific vaccines that are targeted specifically to a particular strain of Group B, like the one that was developed in New Zealand. But these aren't a long-term strategy because a new one needs to be developed each time a new strain is causing an epidemic. So after a long sort of search for a universal Group B vaccine, there are now two Group B vaccines on the market, and the 4C MenB, or Bexsero, its trade name, is a vaccine that is made through recombinant technology, and it contains 4 antigens that are immunogenic, which are listed there, including that outer membrane vesicle that's come from the New Zealand vaccine strain. And those, while not universal to all Group B strains, cover broadly most of the Group Bs, and so that it's considered a sort of near universal vaccine. However, it isn't effective against carriage, and so it doesn't have that role in herd protection. The second Group B vaccine is the Tremembra vaccine, which is against 2 subfamilies of the factor H binding protein, one of the other antigens, but that's only licensed for use in older children and isn't used here in New Zealand. So the 4C MenB, or Bexsero, was added to the childhood immunisation schedule on the 1st of March in 2023, after lots of long lobbying and hard work from the public health sector. It's funded for 2 doses and a booster for children on schedule in their first year of life at 3 months, 5 months, and the booster at 12 months. And there's also been a catch-up campaign in place, which runs until the 31st of August this year for all children under 5. And just to note that if your first dose is given after the age of 2, that booster is not required. So just 2 doses provides adequate coverage. At the same time, it was also funded for young people aged between 13 and 25 who are going into a closed living situation. That group had already been eligible for the funded ACWY, and then Bexsero has been added to that. Understanding coverage in that population is really difficult because there's not really any way to know the sort of denominator, and it's a changing group of who is in a closed living situation. So I have some brief data on coverage before I get into the epidemiology charts. This is provided from the Intelligence Directorate, which is data from the Aotearoa Immunisation Registry. And the top table is showing coverage for all ethnic groups. This is looking in just young children. The first column is the percent that were fully vaccinated in September of last year, so sort of relevant to the time period that I'm presenting the epi data on. And it shows that at that time, babies between 3 months and 5 months, just over 2/3 had had 1 dose. And 5 months to 12 months, just a similar number really had 2 doses. Looking at the older children from 15 months to 4 years, well under half were fully vaccinated, although that's made a bit tricky by the catch-up campaign, and 2 doses would be counted only as partially vaccinated. But even if you add the partially vaccinated, it's still pretty low coverage numbers. They've improved a little bit when you look at the data more recently in June of this year, but still there's a long way to go to get the coverage up. And I know there's a lot of focus in the immunisation sector on this. And the second table just shows the coverage in Māori, which is particularly important because the burden of disease in young children is particularly in Māori. And as you'll see there, the coverage is lower for Māori, and that again is a really important priority for action. So bringing us to the incidence of meningococcal disease in more recent period, since 2015 to 2024, this chart is showing the rate per 100,000 for all cases confirmed with lab detection of Neisseria meningitidis and for all groups. And the main striking feature that you'll note there is the significant decline that occurred in 2020 with a huge drop from the quite high rates that were seen in 2019. And that, of course, is the impact of the COVID-19 pandemic response, the border closures, all the social isolation that had a big impact on circulation of bugs spread by the respiratory route and likely would have decreased transmission of meningococcal, decreased strains coming across the border. But also, as you'll recall, there was almost no flu that year because of the sharp lockdown we had in March and April. And influenza is often a triggering infection or has sort of a strong association with meningococcal disease, and that likely contributed to this big decline. Most countries globally also saw this during the COVID pandemic, although in the Northern Hemisphere, that big drop-off was really more seen in 2021 because of the timing of their winter season. And the pleasing thing in this chart is that while it has increased again since 2020, the rates overall are far below what they were on average in the years leading up to the COVID pandemic. This chart is looking at the number of cases by group. And I had an animation that won't work on my PowerPoint, I apologize. But this is just to show you the lines one at a time. But the group B line is in purple, and that's the most numerically the highest number of cases in New Zealand are group B. And you can see that group B really dropped off in COVID, but it's the only one that has sort of come back up since. The other main thing to highlight here is the line in blue, which is cases of group W. And you'll recall that there was a sort of epidemic of group W with a big increase in 2018 and 2019, including a community outbreak in Northland, which led to a targeted vaccination response. And group W cases dropped off in the COVID 2020-2021 period, and they really haven't come back since. This is also something that's been seen in quite a few other countries, such as Australia and the UK, although in those countries they have implemented a more widely targeted ACWY vaccine program. This just shows that same information, but looking at the proportion of cases by group per year. And the sort of thing to highlight here is that since COVID, group B remains or has sort of returned to becoming the most prevalent strain causing disease in New Zealand. Again, sorry, these are meant to be animated, but just looking at them all together, this is looking at the incidence of disease in different age groups, and particularly those two or three different vaccine eligible age groups, as well as adults older than 26. So firstly, looking at the top left, the incidence among infants under 1, this is a particularly vulnerable group to invasive meningococcal disease, and you can see the rate there is much higher than it is for other age groups. And group B cases in these young babies had that big sort of 5-fold decline in 2020, but actually increased quite dramatically back up in 2021, and 2022 remained high. And in 2021, you'll recall there was the bubble with Australia that led to a big RSV outbreak in infants, and it may be that that was partly related to what drove disease back up in these young babies, because in all other age groups it remained fairly low in 2021. In children aged 1 to 4, the numbers are fairly small and the rates bounce around, but broadly you can see that in recent years it's lower than it has been prior. That's not so true for the incidence among young people aged 13 to 25. While they had a big decline in 2020, it's been slowly increasing since. In the last 2 years, rates were sort of comparable to what they'd been prior to the COVID pandemic. And then lastly, in older adults, so these are not eligible for vaccine, and there's not expected to be any indirect protection like there is amongst the IPD data that Andy was presenting. Interestingly, cases in this age group really dropped off in 2020 and haven't really returned since. So that is really showing us the kind of secular trends underlying what's happening with meningococcal disease in New Zealand and how big that impact of the COVID pandemic has been on the epidemiology. And so now looking at that big question of what can we say about the impact of Bexsero in New Zealand since the introduction to the childhood schedule. These are incident rate ratios that we've calculated looking at the average annual rate in the 5 years leading up to the COVID pandemic in the first column, and then the average annual rate in 2023 and 2024. Meningococcal cases typically peak in winter and spring, and so the vaccination campaign, while it only began in March, it was ahead of that usual seasonal increase. So we've included that very first year of the vaccine campaign in our analysis here. And the pleasing thing is to see that those rate ratios are really promising. The under ones, there's been a nearly halving of incidents compared to that earlier period, and even more so for the 1 to 4s, although there's quite wide confidence intervals around that estimate. For the 13 to 25-year-olds, and as I showed in the chart, the incidence actually really hasn't been any lower in these last 2 years compared to pre-COVID, and that rate ratio spans across 1. And of course, the vaccination in this group is very targeted, and it's not clear how well it's uptaken by those who are eligible. And it's also true that cases occur in this age group even without that risk factor of living situation. So there's nothing, these data don't sort of support any change since the vaccination expansion in that age group. However, as I noted in those charts, amongst adults older than 26, there's actually been a similar halving of incidence, and this is this group's not eligible for vaccine, so this is a change that's happening regardless of the vaccination campaign. And just a couple more slides. This was just to highlight what I said earlier, and this is data from last year, so when case numbers have been lower, but wanting to just reiterate how much of the disease, particularly in young children, is in young Māori children. You can see in those first 2 columns, 12 out of 15 cases in children under 5 were in Māori. And so improving vaccination rates in those Māori young people is an absolute priority for reducing the burden and inequities of burden of meningococcal disease in New Zealand. That brings me to my conclusion, so it's good timing. The main things we can take away from this is that incidence of meningococcal disease was lower in 23 and 24 overall, and for Group B specifically, compared to the average of the 5 years leading up to the COVID pandemic. However, the COVID pandemic response measures have profoundly impacted the epidemiology of meningococcal disease, both globally and in New Zealand. And as that final table showed, Group B incidence is lower for vaccine eligible and non-vaccine eligible age groups in 23 and 24 compared to those pre-pandemic years. So while it's not possible to disentangle the impacts of Bexsero from the impacts of the COVID pandemic, it is a really promising thing that incidence has declined, and particularly for those under 1-year-olds where the burden is high and the consequences are great. But there is a huge way to go for vaccine coverage, and that is a really important thing to focus on to achieve further gains and reduce the burden of this really severe disease. I think I have one last slide, which is just to mention some of the ongoing work at PHF Science. We obviously will continue this monitoring of Group B, and as the vaccination coverage increases and it's been on the schedule for a longer time to understand more about the impact it's having. We also monitor for breakthrough cases, so cases of disease of Group B among individuals who have been vaccinated. And there's a lot of work undertaken by the reference laboratory, in particular Sarah Hannah is a PhD student who's working with UNIREN to do a lot of more in-depth look at the impact of the COVID-19 pandemic on circulating strains at a genomic level to understand what has happened there, as well as using genomics to predict coverage of Bexsero in an ongoing way within New Zealand, given the currently circulating strains. So I think I'll leave it there and I'll stop sharing because it's not great.
Thank you very much, Hannah. That was very informative. We have one question from Phil. Hi, Hannah. I note you confirm that Bexsero has no direct impact on carriage. What data do we have on trends for carriage rates of Group BN across the motu?
We don't have carriage data in any of our surveillance system, but there is I believe it's a TANIFA funded project that UNA ran at PHF Science is very involved with, as well as in a partnership with many others, that's undertaking, I think, repeating a carriage study that for the first time in a number of years. So once that data collection, which I think is just getting underway, is put together, then we'll have a much better picture on carriage. I don't know to the extent that they are looking at or considering the implications of vaccine, but I imagine not, considering the international data is, and the biological data doesn't suggest there should be any impact on carriage.
Thanks. And another question here before we jump to Peter. It's a very good question. How much impact has the dis and misinformation around vaccines had?
I mean, yeah, it's a great question, and it's I guess it's not directly measurable, but it's very obvious in our childhood vaccination program. There's many contributing factors, but coverage is substantially lower than it has been in the past. I think the meningococcal vaccines, the catch-up campaign, I think it's always tricky to get uptake of something that's not routine. And the meningococcal vaccines are very reactogenic, so that I guess for people that are sort of have some fear or mistrust, seeing the sort of fever and things that it causes in a child, it can be a slightly trickier vaccine to be keen to give to your young child. But in terms of, I think there's a lot of things contributing to the challenges in getting vaccination coverage up, of which mis and disinformation are an important one, but also healthcare access, and there are many other things that need to be addressed too.
Yes, definitely. We've got our work cut out for ourselves, Hannah. Peter.
Thank you for presenting, Hannah. I have a comment more than a question. I'd just like to say that I thoroughly enjoyed that, and I really liked it how you took us, when you took us through the graphs, you showed us the highs, the lows, the anomalies and the key points of the graph. I think it's a great example of public health intelligence, because not only do you know your data, but you know your subject as well. So thank you very much for a very informative presentation.
Kia ora, Peter, and I'm glad that prevailed despite my technological problems. I'll work on those.
It sure did.
Another question here, Hannah, from Mary. Do you think coverage is impacting the protection in adolescents? Would a universal meningococcal vaccination program be better?
Kia ora, Mary. I think probably all of us would agree that a universal program would be wonderful for adolescents, young people. And there's always, obviously, very targeted programs, can be much more cost effective, but universal programs absolutely do better at reaching even those that are that are high risk in those targeted groups, because it just makes the sort of delivery and accessibility much more available. So I think that's would be a really important thing for Pharmac and the sector sort of to keep on their radar for consideration.
Yes, very much so. Totally agree. Well, thank you very much, Hannah. That was a wonderful presentation. I note that our next speaker has arrived. We do have 4 minutes if people want to go grab a cup of coffee or a cup of tea and something to eat. I think we did have in the agenda some time for a discussion and to look over the Mentimeter. But yeah, feel free to grab a bite to eat or a coffee and join us at 12:10. Is that right, Patrick?
Yeah, that's absolutely fine. I will leave the Mentimeter up so people know where to go and what they're doing.
Nice. I see Kerry's joined us. Hi there, Kerry. It's great to see in this Mentimeter things like leadership and direction, because I think that's to achieve most of these things, you need leadership and direction, and ownership's a good one there too. Mm-hmm. Great to see environmental health is still on the top, Patrick.
Especially since that's my field, coincidentally.
Very biased. They are two very different topics, though, aren't they? Environmental and occupational health can be easily separated into
That's
their
very
own.
true, but they can't be easily separated when you have 8 other things clogging up the screen.
Yes.
All we need to do, Tim, is convince those with the money to allocate it like that.
Yes, that would be wonderful. Especially things like mental health services and outreach to vulnerable groups.
Interesting though, when you look at it, infrastructure, and yet the current government is that's where it's pumping all its money into.
I also like it that staffing and wages is just above average too, because there's a lot of shortage of doctors and keeping nurses in, and you hear about people moving across the ditch all the time. So yeah, we've got to support that as well.
So the numbers you're seeing are the average number of millions of dollars that people who've responded to this part of the survey think should be assigned to these different groups.
What would be interesting then is to allocate the actual amount of money the government spends on each of those, see how they correlate.
Might be embarrassing, Barry.
PHONZ could do it because it's independent.
Yes.
And mental health is one of the government priorities of the current government, and particularly in young people and young Māori people, it's a really high priority.
Yep. Well, shall we get started?
I think we can come out of there, yes.
Welcome back. If you've nipped off for a quick cup of coffee and a bite to eat, we'll get into the afternoon's session, and I'd like to welcome Dr. Kerry Sexton. Kerry is the Chief Clinical Advisor and Public Health Physician in the Office of the Director of Public Health at the Ministry of Health. Kerry has a wide range of public health experience, with a particular focus on population-based screening programs, immunisation and surveillance. The title of Kerry's presentation is Reporting Standards for Immunisation. Welcome, Kerry. The floor is yours.
Thanks, Tim. Pleasure to be here. I'm a bit nervous about using Zoom, so please let me know if you can't hear me, and I'm going to try and attempt to share my slides, so please confirm when they're up.
Okay, we can hear you nice and clearly.
Thank you. Can you see the first slide there?
Yes, we see that wonderfully.
Oh, great. Okay, thank you very much. Okay, so kia ora everyone. As Tim's already mentioned, I'm Kerry Sexton from Karina Gray's team in the Office of the Director of Public Health. And I'm going to be talking about some work we did to develop standards for strategic level reporting of immunisation data. First of all, I'd like to acknowledge some people. First of all, Izzy Foley, she actually did the bulk of this work when she was a registrar here last year. And I'd also like to acknowledge Antoinette Rigarts, who's taken up the challenge of finishing this work. So this is a work in progress that I'm presenting for you today. And also thank all the people that we've spoken to and who've input into the work as well. There's been a lot of those. Okay, so off we go. So in this presentation, I'm going to talk a little bit about vaccines, and then I'm going to move on to talking about how the work came about, what we're aiming to achieve, a little bit about the immunisation schedule. It's quite complex, and how we've traditionally reported immunisation data. And then I'm going to talk a little bit about the international review that Izzy did, and then wrap up with our recommendations and some of the next steps and ongoing challenges that we're experiencing. Okay, so I've given away something. 1 moment, I'll go back. But first of all, because this conference is for people who love data and graphs, and I don't actually have many graphs in my talk, I thought I'd start by randomly showing my favorite graph from recent times. So vaccines are amazing. They are one of the most successful public health interventions. And you're about to see that measles, mumps and rubella vaccine is the superstar. You just got a quick glimpse before. Okay, so this graph was published in The Lancet last year. To mark 50 years since the start of the World Health Organization's expanded program on immunisation, the authors modeled the impact that the program had had. So you've got 3 graphs there. Sorry, the font's quite small, but I'll explain it to you. So the x-axis on each of the graphs are the years from 1974 to 2024. And then starting with the left figure, the y-axis shows cumulative deaths averted over the 50 years of the program. And what's that showing is 154 million deaths have been averted. In the middle, it shows the cumulative years of life gained, and there's 9 billion of those from the program. And then on the right, it shows the years of living in full health that have been gained, and that's 10.10 billion years of full health gained. And the colours are the various diseases, with orange clearly the greatest contributor across all of those 3 measures, and that's measles. That's why it's such a superstar. It's just really had a huge impact. I also like how these graphs show the differences between the relative contribution depending on what you're actually measuring. So when you get to the right-hand graph, you can see that the green is becoming much more prominent, and that is actually polio vaccine. And what it's showing is that it hasn't really impacted on deaths, but by preventing lifelong paralysis, it's contributing significantly to the years of full health gained. So that's my favourite graph, just to start us off, but I thought I'd better move now onto my actual talk. So these next graphs show why there's been increased attention on improving immunisation in Aotearoa. The graph on the left shows the percentage of children fully immunised at 24 months of age for those who turn 24 months in the quarter, the specific year and quarter. And it's for 3 years, and it's the period leading up into this work that where everyone was getting more and more concerned. The dotted red line is the internationally recognised target. And that's 95%, because that is the level we need to prevent outbreaks like from measles. You can see that even at the right of the beginning of the graph, as COVID was just kicking off, coverage was below the target for all of the lines on the graph. Pacific was started up at the top there with the highest coverage, but has dropped over time to the same as the total population, which is the dark black line. And then by the end of the graph, non-Māori, non-Pacific was at the top. And then Māori, which is at the bottom line throughout. And not shown here is the coverage has continued to decline after this period, not much recovery into 2023 and 2024. Now the figure on the right shows the other concerning feature more closely, and that's the equity gap. The equity gap for Māori versus non-Māori Pacific is the dark blue one, and the Pacific is in the teal. And it clearly shows that there's a worsening equity gap over this period, and this extremely large gap of above 20% for Māori. So this is why people were getting increasingly worried about the immunisation rates in New Zealand, and it contributed to the government introducing a specific IMS target in 2024. And this government target is aiming to get all those lines up to the red dotted line by 2030. And before I move on, I just wanted to talk about some other contexts, is that before the health targets were introduced, the new National Immunisation Register, Aotearoa Immunisation Register, went live. And while in the long run it's going to be really great for reporting, at the beginning it has introduced some more challenges for reporting data because of all the IT changes going on, and it also amassed some long-standing data quality issues. So all of these things together created this intense focus on immunisation data, with increased demands for more and more reporting and increased scrutiny and confusion about what was being reported. So this is sort of like the context for which kicked this project off from the PHA. And we decided to focus first on just childhood immunisation because that was the most concerning area and a government target. Okay, so the intent of the standards work was to agree on what would be the core set of measures that should be used to monitor how well the system's performing and how we're going at reaching that red dotted line and achieving equity. And I want to stress that the project was all about strategic level monitoring, because that's what the Ministry of Health's role is. It's not about all the reporting that people need day to day to do their jobs and operational. Okay, so in particular, we want to create a shared understanding of what's being reported, how frequently it should be reported, why we're reporting it, and clearly define a methodology so there was no confusion. And now I'm going to, and also to increase access to some data that wasn't easy to come across, to find. So now I'm going to talk a bit more about the data itself. And when I first started working in immunisation, I thought the reporting was going to be like super easy. I thought it's going to be simple, but it's actually super complicated. So I'm going to try and explain a bit about the complexities so you can get a bit of the picture. This is what I've learned since I'm working in IMS. Okay, so first of all, there's the immunisation schedule, and that's all the vaccines that are provided free of charge. And there's multiple different vaccines against different diseases, and they require different numbers of doses and different ages. So here's a slide that's trying to show this. On the left, you've got the age at which a child is recommended to receive the vaccine, and that requires like a minimum of 6 different visits to get vaccines before someone's 5. Then column 2 shows the currently recommended vaccines, and you don't need to know what all those abbreviations mean, but I'd like you to know that there's usually 3 different vaccines given at a visit. And then some of the vaccines are for multiple things. So the top one with all the dashes and lines covers 6 things: diphtheria, tetanus, pertussis, polio, hepatitis B, and Haemophilus influenza. So the schedule itself is quite complicated. And then for reporting purposes, the analysts and the data gurus, they also have to take into lots of things that happen just in the real world, such as vaccines might be given too close together or at the wrong age, and so they don't count, or parents want to split and they think 3 vaccines in one go is too many, or someone might be vaccinated at a different age, which means they need fewer doses or more doses, and then children arrive from overseas and they might have a different schedule. So the data that the analysts and data people need to take all this into account when coming up with our coverage rates. So it's quite complicated. And then I'm just now going to move on to what to report rather than the schedule. And in New Zealand, we've traditionally focused on reporting something that we call milestone reporting, which you can see along the top of that table there. And they measure the proportion of children who've received a set of vaccines for that age, and there's 7 of them, going from 6 months to 5 years of age. And I've already shown you some reporting from the 24 months milestone, which is the government target now. And now I'm going to move on to a more complicated version of this table. Okay, so brace yourself. Okay, So this color coding is, I'm trying to show you which visits and which vaccines are included in the milestones. And some of the things you might notice are some of the vaccines aren't included at all in the reporting. Those are the ones in the white rows. There's a rationale for this, but I haven't got time to go into it today, but I can explain later if you like. And some of the milestones are measuring exactly the same vaccine events. So like all the ones in blue are measuring exactly the same events, but at different ages. And I want to emphasize that these milestone coverages are useful. And I think I've demonstrated that by showing how the 4-month one has sort of raised the alarm about poor coverage and rising inequity. But they don't actually cover all the things that we might want to be monitoring. For example, we want children to receive things on time so they're protected. And we don't know whether, because it's like a composite measure of lots of vaccines, we don't actually know whether the individual vaccines, what their coverage is, at higher or lower for some of the vaccines in that set. And another thing we've been trying to grapple with recently is like we're worried about measles, but we don't actually, you can't tell from this data, you know, where are the current population gaps? Who are the groups at risk? Do we need to do some catch-up campaigns? Are we at risk of an outbreak? So that's some of the limitations of this sort of milestone reporting approach. So for this reason, Izzy looked at what other countries report publicly. And she also looked at various, not just the milestone reporting, but other aspects. But again, I don't have time to go into detail today, but I'm happy to share that. And now I'm going to show you what she found out. So this table compares our milestone reporting with what other countries report. So you've got the countries on the left there. And then the sort of little pictures are supposed to sort of help show which countries do the combined one, like us, which is all the different coloured ones. And the yellow is indicating which countries just only report like one vaccine at a time. And so what we were surprised to learn is that New Zealand was an outlier. So we have these 7 milestones, and the maximum you can see there is 3 for other countries. The other thing that I think is quite clear is that we're kind of a bit of an outlier as well, in that we are continuing to do these combined milestones, whereas other countries are just doing mostly individual vaccines. So this greatly influenced what our recommendations initially were, and I'm now going to talk a little bit about those initial recommendations for you. Okay, so our initial recommendations were that we need to rationalise those numbers of milestones down because we were clearly an outlier. And so we were recommended to go to 3, and the sort of most common ones that you saw in that prior table. We also are recommending that we need to start publicly reporting individual coverage for individual vaccines, and also that on-timeness, because we really want children to be receiving them around about the time that they are on the schedule, because that's why the schedule is designed with those ages, to protect those children. We also strongly recommend that for strategic purposes, like how well are we going, we should not be reporting more than quarterly, because there was increased pressure at the time in the past to start doing things like these milestone reporting every week. And we're trying to convey that reporting stuff, something like that is not useful on a weekly basis. We also are recommending time series analysis publication, because currently it's largely just spreadsheets of individual years that you can access easily. And we want reporting by ethnicity, NZ depth, geographic area, and equity analyses using Māori Pacific and non-Māori non-Pacific. And is that my time up, is it, Patrick?
That's your 5-minute warning.
Oh, 5 minutes, thank you. Then we're also recommending that we need to develop measures to analyse that thing I was talking about, like what is the actual population risk right now. And then we also need to document the methods to ensure consistency and clarity. So these were the recommendations we came up with last year, and I do need to say that some of this is already in progress. Like the Health New Zealand team have been working really hard on all the various immunisation data, and some of these are now being produced internally at least. So yeah, but at the time, these were our recommendations. Okay, so then just to wrap up, I just thought I'd say now, what are we doing? What are our next steps? So at the time, I said we focused on childhood, but we think we need to expand that to include other ages because, again, for clarity and access to data. So, for example, antenatal immunisation is really important at the moment for pertussis, given we have an outbreak. We're going to, so therefore we're going to expand the standards and they're going to incorporate the feedback we got, which was largely supportive. And then we're going to go out for more consultation and more widely. There were some sort of ongoing questions that we didn't address the first time round, and we'd focus more the first time round on what to report. We didn't really focus on how, and I imagine today you've been seeing lots of different ways to present data. And what that's sort of brought up for us is there isn't really a New Zealand standard about how we should present health data that we're aware of, what colours to use, when to use a graph, how to how to summarise things. There is obviously the ethnicity data reporting protocols, but that's largely the only one that we're aware of. So we're interested if anyone knows of other standards that are out there that we should be following for publication. Also, do we need to define how soon this data comes out to maximise its benefit, and where and how to publish it? Because some stuff I said is being internally published, and there's only limited currently out there for everyone to access. And the other key consideration at the moment is that these 7 milestones are actually tier 1 statistics. So if we recommended reducing them, what are the consequences of recommending a change to tier 1 stats? So to finish, I'd be really keen to hear if anyone else, like I said, is working on standards like this, because we're keen to compare and use what your insights to date. Also keen to know if anyone's interested in being consulted in our next round. Keen for other people's expertise to feed in here. And just to thank you for listening. Sorry there wasn't as many graphs as I'd hoped. I love a good graph, but I tried to get a few in there. Thank you.
That was wonderful. Thank you very much, Kerry. And definitely some good work being done. Over to some questions. Got some question here. Great work, Kerry. Can you clarify whether reporting by antigen or vaccination, I know these will generally amount to the same thing, but if parents choose to split vaccine components, it might be important to capture antigen-specific coverage.
Yes, I think that's a good point. So and it's also covered by that, the overseas individuals coming in. So, that one I had at the top that had all the 6. And in the UK, for example, they don't do hepatitis B. So people might be given that individually. So currently we're wanting to do it for the vaccines, but in some areas we may use the individual conditions. So like hepatitis B, for example, might be one that we want to do separately to capture all kind of ways it might be given. So as it is, work in progress. Yeah, good question though.
And a nice comment from Karina saying great stuff, Kerry.
Oh, she's my boss. She has to say that.
Another question here for you. Thanks, great presentation. How is maternal vaccination data currently being collected in New Zealand, and how can it be improved in likely future directions?
Yeah, so I can't see who else is on here, but I can describe what I know. But as I mentioned, Te Whatu Ora, the Intel team are largely doing this. But the way they currently do it is they look at, they do it retrospectively. So they look at all the deliveries in a 3-month period, and they look back to see whether the parent, the pregnant person, was immunised for those live births. So it's not ideal. It's not done while the person is pregnant. It's retrospective, but it is useful for seeing the trends and whether things are improving or not. And I think there will be over time, I understand, looking at like when we have a better maternal database to use that as a source. But there may be another person more expert than me on the call. Yeah.
Another good question here from John. Why are rotavirus, Bexsero, and varicella not counted?
Yeah, so each for different reasons. So the rotavirus one is not in there because it actually, if you don't, you have to receive it by a certain age. And if you haven't received it, then you become no longer eligible. So it makes the reporting quite complicated. So this is another reason why it's useful to start reporting separately for things like rotavirus, because it's really important to understand who is and who isn't getting it. But that's not currently available. For meningococcal B, I think I heard Hannah talking about how it was a recent introduction. So there is usually a time period that elapses before you are included in the milestone, because otherwise the milestones all of a sudden go just really skew if. So yeah, but again, that's why we'd really like to have publicly available MenB data so you can actually see what's going on. And for varicella, that's chickenpox. And so this one is a bit complicated because of a lot of children in the past had chickenpox. So, and there was a bit of confusion about whether you still should get a chickenpox vaccine. So again, it was left out because of that complicating features of it. But again, it would be great to see chickenpox specific coverage to understand what's going on.
Nice. We have a question in from Michael. How would 3 reporting milestones work given the minister's proposing linking PHO payment boosts to 6 weeks events by 3 months? Wouldn't that need to be retained?
Well, it depends on, so this, as I said, this is what we want, like say as a Ministry of Health with our performance monitoring lens on what we think as a public health agency is important to monitor from the system perspective, but it doesn't mean that we will stop reporting or I can't collect other data for other purposes. So, but it is a good point to raise. Maybe one of the milestones should be a year earlier.
Good question. Thanks, Michael. Nice. Well, that was an absolutely wonderful presentation. Thank you very much, Kerry.
Thank you.
We'll move on to our next presenter now. It's wonderful to go over the ditch. It's lovely to introduce Michelle Gourley. Michelle is the current head of Burden of Disease and Mortality Unit at the Australian Institute of Health and Welfare, which is Australia's national agency for collecting, analysing and reporting on health and welfare data. Michelle has 10 years experience in providing national leadership on work on burden of disease in Australia, including leading current work on the Australian Burden of Disease study. During Michelle's career, Michelle's led the development and release of a wide range of publications, which provide evidence base for informing key health policy questions, health priorities for government decision makers. Very nice to meet you, Michelle.
Yes, I'm certain there would be. Of course, Michelle is providing us with a pre-recorded presentation today.
She's online here.
Oh, is she? I apologise.
Hi everyone. Yes, I've joined to listen, but I would prefer if you play the recorded presentation, if that's okay, and I'll be around to answer questions at the end.
Not one for improvising. Fair enough. Oh, here we go.
Good afternoon, everyone. My name's Michelle Gourley, and I head the Burden of Disease and Mortality Unit at the Australian Institute of Health and Welfare. Today I'll be talking to you about the Australian Burden of Disease study and how we use data from this study to help inform policy decisions in Australia. I'd just like to start by acknowledging the traditional custodians of the land upon which we meet today. And I'm coming to you from Canberra, which is the land of the Ngunnawal peoples. I also pay my respects to elders past and present and extend that respect to any Aboriginal and Torres Strait Islander people who may be listening today. So a little bit of background on the Australian Institute of Health and Welfare. We are Australia's national agency for health and welfare statistics. Our vision is for stronger evidence, better decisions and improved health and welfare. We publish over 200 reports annually, covering over 75 different health and welfare topics. And we provide a full range of data services from data requests and access to data sets through to analysis and linkage services. Different topic areas we report on is burden of disease, and this aims to quantify the health impact of different diseases or injuries on a population by measuring years of healthy life lost from living with disease and injury, or dying prematurely. Another way of thinking about burden of disease is that it measures the gap between the ideal of living to old age in good health and reality, where healthy life is shortened by illness, injury, disability, or premature death. And burden of disease is often considered one of the best summary measures of a population's health. Burden of disease is measured by three main components. The first is fatal burden, where we use information on the number of deaths, the age at death, compared against a standard life expectancy to calculate years of life lost, or YLL. Non-fatal burden, we use information on the prevalence or the number of cases for a different disease, the duration or severity of that disease if relevant, applied to a disability weight, which is a measure of the severity, and this is used to calculate years lived with disability, or YLD. And we combine these two measures together to estimate the total burden, and this is measured in terms of disability adjusted life years, or DALY. And one DALY represents 1 year of healthy life lost. Burden of disease analysis also enables the quantification of the contribution of selected modifiable risk factors to this disease burden, and this is called attributable burden. Attributable burden is the amount of disease burden which would be reduced if exposure to the risk factor had been avoided. And for this type of analysis, we often use a comparative risk assessment methodology, where we get information on the number of people in the population exposed to the risk factor, evidence in the literature around what diseases are causally linked to that risk factor, and the size of that effect, which is often relative risks. And we use this to calculate population attributable fractions, and we then apply this to our disease burden to calculate attributable burden. The Australian Burden of Disease Study produces estimates of the burden of disease in Australia for around 220 different diseases and injuries and 20 modifiable risk factors. It's been undertaken by the HW since around 1996 with funding from the Department of Health, Disability and Ageing. The latest study that we published was in December last year, and this was our 2024 study. And this used a fairly new approach where we estimate or project our estimates to the year of publication using historical trends. We also undertake a separate study for our Aboriginal and Torres Strait Islander population, and we publish a range of different outputs from these estimates, including key findings reports and interactive data visualizations. Now let's take a look at the history of Australian and international burden of disease studies. In 1990, the World Bank and WHO produced the first international burden of disease study. And then from around 2010, the Institute for Health Metrics and Evaluation within the University of Washington then produced what we now call the Global Burden of Disease Study, which included a number of major methodological advances which really paved the way for future burden of disease studies, including country-specific studies. And in Australia, we've produced 8 national studies so far, with our 9th one underway, and 3 studies for the First Nations population, with the 4th one underway. The Australian Burden of Disease Study largely follows the Global Burden of Disease in terms of its methodological framework, but we've made some major modifications to better suit the Australian policy context. For example, we have our own Australian-specific disease and risk factor lists. We've produced a methodology to enable Indigenous-specific estimates and estimates of the gap between Indigenous and non-Indigenous populations. We've got better access to more detailed, recent and direct Australian data. So a majority of our estimates come from a single best data source, and we often have access to unit record or linked data, which means that less modelling is required. We have all of our methodology and our estimates reviewed by Australian experts. We have a high level of transparency in terms of access to all of the detail behind our methods and our published estimates. Having a country-specific study also gives us potential to do our own extension type analysis or tailored reports for different policy users or stakeholders. We've also developed our own data quality framework for assessing the quality of the estimates. And we've really built our system and our database here for burden of disease estimates to enable efficient and ongoing updates. So it's really been set up as a national asset. We use a range of different data sources in our burden of disease estimates. So this can include national administrative data collections, such as deaths or hospitalisations, population health surveys, disease registries, which may be national or state-based, for example, cancer or HIV, also surveillance data for infectious diseases. And then we also draw on large-scale epidemiological studies, as well as linked data, such as hospital and deaths data. The IHW has recently established the National Health Data Hub, and this is an enduring de-identified linked data system that brings together a number of different health data sets. And you can see these listed in the slide here. So this covers data sets like mortality, hospitals, aged care, immunisation data, pharmaceutical data, Medicare data, just to name a few. And we use this in the burden of disease analysis to help estimate our prevalence for a number of different diseases or injuries. So what are burden of disease estimates being used for in Australia? Well, the IHW undertook a stakeholder survey late last year where we asked respondents how they were using data in our reports. And the majority of stakeholders said they were using burden of disease data to identify health priorities or to contribute to government health reports, to be used in health policy directly, also for things like briefing ministers and policy briefs, as well as contributing to evaluation measures and inputs into modelling, also support for prevention and health promotion activities. So this slide here shows our headline burden of disease statistics in terms of trends in total burden, fatal burden and non-fatal burden. And this is used quite a lot to show whether Australia's overall health is improving. And we have seen a 10% reduction in the age standardised rate of total burden of disease in Australia between 2003 and 2024. However, this is largely driven by large declines in fatal burden. But the key thing here is that we are actually seeing increases in our non-fatal burden rates. So that's the number of people that are living with diseases and injuries as opposed to dying prematurely from them. And this is really something that our government and our policymakers have focused on. Similarly, health adjusted life expectancy is another really good summary measure that comes out of burden of disease that is used quite a lot in government reporting in Australia. So HALE extends the concept of life expectancy to consider how healthy people are while they are alive, and it measures years lived in full health. So we know that Australians are living longer by our increases in life expectancy. But what people really want to know is, has there been an increase in the years people are spending in ill health? And this graph here shows a comparison between 2003 and 2024. And it shows that actually, yes, as Australians are living longer, we're seeing an increase in both the years spent in full health and the years spent in ill health. So really our proportion of lives spent in ill health as we get older hasn't changed much over time. So burden of disease measures such as HALE are often used as targets in national health strategies. And one good example here is the National Preventive Health Strategy in Australia. And this includes a number of different aims. And one of these is that all Australians live in good health and well-being for as long as possible. And here we can see our health adjusted life expectancy data used as a target. So these are that Australians will live for at least an additional 2 extra years of life lived in full health by 2030. And here, each year that we release a burden of disease study update, tracking against the baseline value is updated to see how Australia is progressing. In terms of identifying health priorities, reporting on disease burden by disease groups can be a good way of showing which diseases are causing the biggest health problems in Australia, and also whether the burden is largely driven by premature death or by people living with the disease or illness. So this slide here shows that cancer is currently the leading disease group causing burden in Australia. It is largely made up of fatal burden. In comparison, mental health and substance use disorders and musculoskeletal disorders are the second and third leading disease groups, but they are largely driven by non-fatal burden. Now looking at the leading risk factors causing disease burden in Australia, here we can see that overweight and obesity has become the #1 risk factor, accounting for around 8% of our total population's disease burden. And this is closely followed by tobacco use, then dietary risk factors, high blood pressure and high blood plasma glucose. And this data has really been used a lot to highlight the increasing importance of obesity as a risk factor and the need for prevention, and has fed into Australia's National Obesity Strategy, which is a 10-year framework for action to prevent, reduce and treat overweight and obesity in Australia. Here we can see the two leading risk factors, tobacco use and overweight and obesity on the left, and we can see there's been a large decline in the burden due to tobacco use over time. And this is due to declines in both the population's prevalence of smoking, as well as declines in some of the key major linked diseases, such as coronary heart disease and lung cancer. And this data has often been used to support the success of public health campaigns focused on tobacco control in Australia. And we can see the different tobacco control measures that have been undertaken over time mapped out in the right-hand figure. And this is mapped out against the long-term trends of people smoking over time. And I should just note here that the tobacco burden figures presented do not currently include vaping. So this has been outside the scope of past burden of disease studies. However, as part of our next major study, which we're planning to release at the end of 2026, we will be looking to include nicotine vaping and potentially also vaping from illicit drugs. Another statistic that's used a lot in government policies and prevention strategies is this figure that 1/3 of disease burden is preventable in Australia due to modifiable risk factors. And in the Australian Burden of Disease study, we currently include 20 modifiable risk factors. And these can be grouped into behavioural risk factors, metabolic or biomedical, and environmental risk factors. Burden of disease estimates can also be looked at for different population groups. And this slide here shows the leading causes of burden in males by age group. And here we can see that if we look at the purple colours, for example, these are mental and substance use disorders. And these are causing the majority of burden in males aged between about 15 and 44. We can also see that suicide and self-inflicted injuries is a leading cause of burden in males aged 15 to 44. And this information can be useful in terms of targeting prevention activities, if there's certain diseases that may be of interest to policymakers in terms of reducing burden. Data from the Australian Burden of Disease study has also recently been used to provide advice to government on how to best to prioritise risk factors for investment or intervention. Work undertaken by the Australian Government Consultancy within the Department of Prime Minister and Cabinet analysed estimates of attributable burden for each of the risk factors included in our study. They looked at how big an issue is the risk factor throughout Australia, measured by its amount of burden, how unequal is the risk factor, measured by the ratio between the burden in the highest and the lowest socioeconomic quintiles, and also has there been improvements over time in both burden and inequality. And from this, risk factors were categorised into 4 quadrants. So the top right quadrant shows risk factors that have grown in both disease burden and also inequality. And these risk factors would be good candidates for whole of population-wide interventions. And here you can see that overweight and obesity is included in that quadrant. The top left quadrant are those risk factors that have declined in terms of burden, so seen improvements there, but they have actually increased in terms of inequality. And this includes risk factors like tobacco use and physical inactivity. And these could be good candidates for prevention activities or public health campaigns targeting those in the lowest socioeconomic areas. Scenario modelling can also be used to look at the impact of different policy scenarios on future disease burden. And this example here shows overweight and obesity, and looking over a 10-year period, how much disease burden could be avoided if trends in obesity stabilised compared to if current trends continued, and also looking at what would happen if everyone in the population reduced their body mass index by 1 point. And this is just one example of the type of scenario modelling that can be undertaken. The HW has produced a number of different reports focused on different risk factors, looking at different scenarios of interest to the government at the time. Australian burden of disease data is also being more frequently used to assess the impact of different public health interventions, either hypothetical or actual. And one example here is the University of Melbourne's Scalable Health Intervention and Evaluation Program, or SHINE. And this has developed a system where a range of different data inputs can be used, including data from the Australian Burden of Disease Study, to then model what might be the outcomes in terms of reductions in health inequalities, cost savings, improved health, and cost effectiveness. And this system has built a range of different tools for policy users as well as researchers. And one of these examples is the Health Intervention Impact Calculator. And this allows users to specify different hypothetical public health interventions and look at what reductions in risk factor or disease prevalence might be expected, and then output gains in health adjusted life years, health expenditure, or workforce productivity. And really the different types of interventions that can be inputted into platforms like this could be endless. So we could look at things like what impact would a sugar tax have on obesity rates and resulting disease burden, or something more specific like removing trans fats from food supply and the impact of that on coronary heart disease burden. AHW has also undertaken work to compare disease burden to disease expenditure estimates. And here we can see that cancer is at the top, being the leading cause of both burden and accounting for the most health expenditure in Australia. When we look at some other diseases, we can see that something like mental health conditions and substance use disorders has a much greater proportion of burden compared to spending. And this is often used as a justification to advocate for more medical research as well as funding into prevention activities for that disease group. We can also see something like infectious diseases has a much greater spending compared to burden, and this reflects the successful vaccination campaigns rolled out in Australia. So what's next for the Australian Burden of Disease study? Well, we have our 2026 study underway, due for release in December next year, and we'll be assessing the inclusion of a range of new diseases and new risk factors based on the latest available evidence and data. So some examples here include diseases like chronic fatigue syndrome or new risk factors, as I've mentioned, vaping, and also a range of different environmental risk factors we're hoping to include. We'll be utilising primary healthcare data for the first time, coming from some of our local primary healthcare networks. We'll be updating our subnational estimates and looking to do small area estimates for the very first time. So we're very excited by that. We'll also be looking at some new outputs like maps and data stories, and also exploring machine learning to automate some of our choices in models such as projections. I'll also just mention that the First Nations 2022 study is underway, and the other piece of work we're doing is a feasibility study looking at whether burden of disease estimates could be disaggregated for culturally and linguistically diverse population groups. And finally, I encourage you all to check out the HW's website to find all of our burden of disease reports and data. And you can also contact the HW BOD team at the email address shown here. So that brings me to the end of my presentation. Thanks very much. And I look forward to taking questions at the end of the session.
It was very insightful. Thank you very much, Michelle. You are online with us this afternoon, so thank you very much for joining us. I see there's a few questions. And here, excellent presentation, Michelle. Have you shown the applications of the ABDS? You have shown the applications of the ABDS very nicely. Thank you. It's a comment, not a question, sorry. And I see there's a question in the question and answer section. Does AIHW looked specifically at the burden of foodborne illness and its contribution to overall disease burden?
Yes, so we don't specifically group the foodborne illnesses together as a category. We do, implicitly capture some of the burden through some of the consequences of those illnesses, like diarrhea or other gastrointestinal disorders and diseases will be picked up. But we don't report, separately on the types of bacteria, for example, that might be causing the foodborne illness in the first place.
Thank you. And there's another question here. Thanks for your talk, Michelle. Really interesting. Just wondering, does Australia have legislation or limits set for environmental noise?
Ooh, not that I'm aware of. I'm probably not the best expert to talk on that. But interesting you do talk about noise, because that is one of the new environmental related risk factors that we're looking to include in our 2026 study. So we have been having a look at what data and evidence is around in terms of like residential noise, around where people live, and also in their workplaces and things like that. So yeah, hopefully we will have enough to be able to include it in our 2026 study.
Yeah, there was a great list of additions, including mold, which is really interesting and really relevant in this day and age. Barry, you've got a question.
Thanks, Tim. Michelle, excellent presentation. Thank you very much for that. There was two comments I'd like to make. One is I was particularly impressed in how the survey you did or got in touch with the users of your data, and even more impressed the fact that the government were prime users of your data. The other one was that it's been used for prioritising investment. I think they are wonderful additions to what the GBD is all about. So any further comments on those?
Yep, I can talk about the stakeholder surveys that we did last year. So that's probably the first time we've done a really large scale stock take, I guess, on how our burden of disease data is being used. And I think we had about 200 participants. So we contacted all of our sort of known experts on all of our advisory groups, researchers, as well as key contacts within the policy departments. And they were actually really quite engaged, and we were quite surprised by the proportion of people that came back that did say they were using it directly to inform policy briefings and ministerial briefings and things like that. So it's really great to see that it has been used for those reasons. And then your second question, just remind me again what that was. That was around
being used for prioritising investment.
Prioritising investment, yeah. So that's something that's pretty new actually for us. So it was work done by a consultancy group who originally did a scan of kind of all the data and evidence around in Australia, sort of linking, I guess, diseases to risk factors and trying to come up with a methodology to then, I guess, provide back to our policy department in terms of how they should be looking at, spending their money and investing in prevention efforts. And they went around in circles quite a lot, but in the end, they came back to the burden of disease analysis that we did, and really thought that that was probably the best overall summary information in Australia. That really is a really good way to put all of the different risk factors in perspective, and also look at inequalities, which was a really key focus for their work. So I think that the slide that I showed that had the 4 quadrants of grouping the risk factors, I think is a really great way to think about the different ways that we can target prevention activities going forward, and whether to focus those on the whole population or, just those in lower socioeconomic areas to reduce burden overall in Australia.
How big is your group?
My team for burden of disease, we've got about 12 staff, I think, at the moment.
It's amazing work coming out of 12 people. I was expecting you to say at least 30 people. Nice. Well, if there's no further questions, I'd like to thank you very much, Michelle, for joining us. It was an absolutely wonderful presentation. Thank you very much.
Thank you. Thanks for having me.
Thank you.
Moving on to our next speaker, and remaining in Australia, it's a privilege to introduce you to Jacob Madden. Jacob is the Assistant Secretary of the Australian Centre for Disease Control Establishment Strategy Branch at the Australian Government Department of Health, Disability and Ageing. It's quite a mouthful, Jacob. In this role, he leads the policy and strategic design for a new CDC in Australia, including developing legislation and negotiating with state and territorial governments. Welcome, Jacob.
Thank you very much, everybody, for welcoming me to this exciting event that you've put together. Yes, it is such a big mouthful when you go through that. It's Centre for Disease Control Establishment in the Centre for Disease Control Establishment Division in the Interim Centre for Disease Control in Australia. So it's really great to be here. I am in Canberra on the land of the Ngunnawal people. So I pay my respects to the traditional owners and custodians of the lands where I'm joining from. So thanks, Tim. I've got a few slides that I will just share and walk through, and wanted today really to focus on what is the work we're doing in setting up the Australian Centre for Disease Control, specifically as it relates to the work on public health data reform, which goes specifically to some of the things of interest to this group around how we can use public health data in a more meaningful way to guide government decision-making, to guide the evidence, and to build that trust and engagement with the public. So the span of my work includes setting up the Australian CDC, as well as this program of work around enhancing public health data and positioning the Australian CDC as a data-driven organisation. So when we talk about creating the Australian Centre for Disease Control, it's happening in a phased way. So what the government here in Australia did was launch an interim Australian CDC within the Department of Health. But from 1 January next year, we will move to being a separate entity. So independent from the department, with a direct line from the CDC to the Minister. Right now at the pointy end of the process to get to that 1 January milestone. So it's a really exciting time and busy time for my team. But you can see there what the vision and mission for the Australian CDC is, and some of the key things that the CDC will do. So I'll just call out like the first and third thing there on the right-hand side. You've got detect and assess emerging health threats and improving national public health data and analytics capability. Both of those things, I think, go hand in hand to address the other two things on that list. So how do we advise government in the most effective way? And how do we ensure that data and evidence are front of mind for the public when they're interpreting or understanding public health advice? So last year, over the course of kind of 2023 and 2024, the Australian government commissioned a inquiry into the COVID-19 response. One of the recommended actions from that inquiry was to improve data collection, sharing, linkage, and analytics capability, particularly for response in a health emergency. So you can see here a couple of the problems that we've identified or that have been identified. I'm sure very common experiences in New Zealand and across the world, particularly in federated countries like Australia. But that kind of national consistency, I know, is an issue that happens across sectors as well. So thinking about data as a critical enabler for the Australian CDC, what is that? What are our opportunities to address some of these challenges here? So national leadership, national consistency, having clear authority, but also having that workforce capacity and capability is all part of what we're trying to address. So when we talk about the role in national public health data for the Australian CDC, we look at kind of what are the purposes. So what is it that we will do and how will we do it? So in terms of what we will do, Australian CDC collect, curate, enhance and interpret data. So it's improving surveillance, enhancing our data linkage capabilities, improving multilateral data sharing, delivering that national consistency and supporting evidence-based and transparent decision-making. But to do that, we need an authorising environment. So thinking long and hard about how we position our legislative framework to support these authorisations, recognising there are a range of existing data custodianship responsibilities. And that's where the strong data governance is really important, recognising at the end of the day, we're talking about individual people's information and we have responsibilities as stewards and custodians of that data. And those data come from a range of different places. And so how do we have a strong governance framework that recognises that, whilst also allowing the data to be used for these purposes here? Consistent methodologies. So we also need to ensure we're both standardising the data where possible and having modern contemporary methodologies for our analytics work. And then, of course, there's a technology layer of making sure that we get things flowing in the most efficient way, whilst also recognising that data governance responsibility. I always like this slide when my team use it and often joke that it looks like a map of New Zealand, but flipped the other way. Here you can see what we talk about as the Public Health Data Network. And at its core, it's about data linkage. And I think data linkage is a real game changer in terms of shifting from kind of static facts to more meaningful intelligence. So one thing that sticks with me from something someone said early in my career, data that isn't used is useless. And so I think we need to, we are very much looking for those opportunities on how we can enhance the data, make it meaningful, and position ourselves as a data-driven organisation where that information can be evidence, can be intelligence, can drive action. So the Public Health Data Network is proposed to be a comprehensive suite of data sets that support effective national action. So prevention, detection, response capabilities at local and national level. When we think about linkage, it's about our notifications data for communicable disease in particular, and other surveillance inputs, so wastewater surveillance program, for example, linking that with demographic, social, and other data sets. So what do we know about culturally, linguistically diverse backgrounds? What do we know about income status? What do we know about geography, for example? And then those two things linked together with health outcomes data. So health-seeking behaviours like immunisation rates, but also outcomes like hospitalisations, use of pharmaceuticals, and other health system utilisation indicators. So the three of those kind of buckets together allow us to build that comprehensive picture and better understand the burden of disease, better understand where and how diseases affecting different cohort groups, understand those risks, and use that information for clear public health purposes. So we're building that data sharing and linkage capability and supporting a range of initiatives that feed into enhancing our public health capabilities. One thing, as I said, that's front of mind is our legislative framework. So what are the guardrails around this public health data network that have privacy front of mind and social license front of mind? So thinking about prescribed public health purposes and prescribed public health entities. So currently in Australia, we're limited in health data sharing, largely restricted to sharing for clinical care purposes or sharing at a level for research purposes. But when we think about public health, whether it's outbreak investigation, whether it's public communications, whether it's identifying areas for enhanced testing or surveillance, all of those things are public health purposes where the data is really useful and needs to be useful in a way which allows us to pinpoint exactly where the interventions might be most effective. But in our federated country, the Commonwealth does not do all of that work itself. And so thinking about how do we then have a framework which allows us to share the information with any organisation that performs one of those purposes. So as I said, privacy front of mind and social license front of mind. So thinking about within this framework being as clear and precise as possible, but also being flexible enough to potential use cases in the future. The more information you have, of course, the more insights we can glean, but within those bounds. So thinking about things like compliance or policing, law enforcement type activities outside the bounds of your public health purpose. Whereas sharing to design an intervention or a program response to a public health threat, that's within the bounds. And so being clear on what that is, and then legislatively making sure we've got things like penalties and a compliance regime for any officials who may share data outside of those bounds. So where are we up to? It's happening in a phased way. Of course, both bureaucracy and government ICT don't necessarily move super quickly. But at the moment, we're finalising our legislation to establish the entity, give it its powers, create this data sharing regime and privacy framework, but also to do a couple of other things such as creating obligations for the CDC's advice to be made public and other ways that we can ensure that we are enhancing that evidence base, using that evidence base and having that kind of data and evidence and intelligence front of mind for decision makers. So that's happening at the moment, and we're looking at how we link notifiable conditions data with our existing data sets and opt-in basis for our state and territory governments who are the original sources for that data. Then over time, implementing this data network and ICT infrastructure, looking at the opportunities that exist with whole of government data integration infrastructure. I know Stats New Zealand has some great linkage architecture similar to Australia. So how do we then also streamline our technical arrangements to ensure that the balancing the custodian responsibilities where the source data comes from, but also streamlining it so that we don't need approvals every single time and have that rapid data linkage solution for when we need rapid insights. And then finally, over the next several years, looking to build a new public health surveillance system. It's a piece of technology that can ingest all of this, as well as your insights from antimicrobial resistance, interoperability with animal health databases, for example, and access to that broader range of data. As I said, it's a really exciting time for us at the moment, and a real opportunity for us, as I said, to shift from just having aggregate level information about disease to having the information in a way where we can enhance it, as well as having the capability within the organisation that we're growing to be able to analyse it and use it. And all of that, as I said, with the aim of improving the evidence base, improving the advice that goes to government, improving decision making, and ultimately better delivery of health services in line with our mission. So I'm going to stop sharing there and see whether anyone has any questions.
Thank you so much, Jacob. That was really interesting. And I think you were saying all the right things that we like to hear. I have one question. Yesterday at the conference, where it was a lot around AI and not only the use of AI, but we also touched on some of the ethical debates. I noticed that in your presentation you had enhanced technologies as one of your actions. Are you looking to include AI as part of your workflow?
Yeah, definitely. So an emerging area across government here in the safe use of AI and how best to regulate its use within government agencies. So there's whole of government work happening, of course, but looking at how we can use AI both for your kind of core business of government. So, you know, your kind of standard use cases of AI tools, but then also within the surveillance. So how we can use machine learning to read big data sets, streamline, clean, etc. What our other potential public health use cases of AI around things like reviewing the evidence that we're proposing against the evidence that exists elsewhere. Some of those opportunities, I think we're definitely looking at. Alongside our data strategy, all of this sits underneath our data strategy, also looking at a digital strategy. So how we use digital technologies across that spectrum. Definitely, as I said, the pointy end as we get close, but a really exciting time to develop all of those strategies from scratch in combination with each other to make sure we're maximising the opportunity.
Interesting. Thanks, Jacob. I see Barry's got a question for you.
Jacob, thank you very much for an excellent presentation, and certainly, as you said, exciting times. We in a one-state system here. The question that I've got is that we've just heard from Michelle, you've got AIHW and you've got a bunch of states as well. So how do you manage the integration or working together with all these things?
Yeah, with absolute joy and pleasure, I would love to say, Barry, but I think with great difficulty. The Australian Institute of Health and Welfare are very well versed in this space. They've got existing mechanisms. They've got a state and territory board, for example. There's the question around how do we bring together data sets that exist in different agencies or portfolios. That's part of your question. And then part of the question about how do we bring together jurisdictions. So the Australian Bureau of Statistics runs what's called the Australian National Data Integration Infrastructure, ANDI. And that has things like the person level integrated data asset already. So information from the census, information from a range of other administrative data sets that they collect. The Institute of Health and Welfare has what's called the National Health Data Hub. So all of your Medicare service data, pharmaceutical benefits data, hospitalizations data, etc. So those two things together, Health Data Hub and PLIDA, effectively will be the spine together with the National Notifiable Disease data, which is what comes from the states to us. And this is where the states then come in. You've got Commonwealth data assets, and then we've got what's already a federated data asset. So part of our solution to get this new notifiable disease data into and alongside the others, looking at how we can use linkage architecture that exists at jurisdictional level, where they're already able to map individuals to a linkage key, and then how we inject that linkage key across into the Commonwealth government systems to then have that linked data set. So I think there's the technical solution there effectively is a federated one where it's pushing out sufficient information for the states to then map their data to a spine that already exists at the Commonwealth level without us having the names and addresses of the people with the cases, for example, because that's all happening. Then there's the governance solution, which is a more complex one. So the intent is to create those public health purposes and to essentially cede the authority in the CDC, Director General. So it's clear that we will use data for these XYZ purposes. And the Director General then has the ability to do that, and that all states and territories agree to that basic premise and those purposes. And so each time we want to use data for one of those purposes, we don't need their agreement again because it's already set out. But if there is a new purpose that arises, making sure we've got a governance structure which allows the states as the original custodians of that data, or ABS, the Bureau of Statistics, if we're talking about using census data in a different way. For example, agriculture, if we're getting animal health data, whoever the relevant custodian is, still having the responsibility and the ability to say, no, I don't feel comfortable with the data being used like that.
Thank you.
Good answer. Yeah. Thanks, Jacob. Well, thank you very much for your presentation. It was absolutely fascinating. But potentially, maybe we could see you next year as well, and you can give us an update of how it's turned out.
I would love that. We've got a strong relationship with New Zealand, work very closely with Fiona and others as part of an international grouping, very much looking at the work that we can lead and the work that we can learn from others. So appreciate the opportunity. Thanks very much.
Invitations in the mail, Jacob.
I'll come in person.
You've got all the money.
Thank you very much, Jacob. Moving on now to our next presenter and the last one for this afternoon's session. It's wonderful to introduce you to Professor Michelle Happy. Michelle is an Australian epidemiologist living and working in northwest Mexico for the last 12 years. Michelle has over 30 years of experience in both academia and government, and has also worked as a consultant on many projects for the Pan American Health Organization and the World Health Organization over the last 12 years. Welcome, Michelle. The floor is yours.
I've got a recorded presentation which Patrick has, but I'll be here for questions.
Great.
All right.
Thank you for the introduction. When Barry first invited me to present at this forum for people interested in public health intelligence, as he described it, I thought he'd got the wrong person. Whilst I did work in what I thought was health intelligence or descriptive surveillance many years ago, for quite some time now I've been more interested in interventions and working within the idea of evidence-informed decision-making for policy and practice. But then after a bit of to and fro with Barry and some thinking, I thought perhaps you would be interested in hearing more about this work that I did recently, which as part of a consultancy for the Pan American Health Organization. on a possible definition for health intelligence, and then talking a little bit more about how that might fit within the concept of evidence-informed decision-making. So I hope you find something useful from it. So what is health intelligence? Well, the short answer is I still don't know. But let me tell you what we did and what we found. So the aim of the work was to synthesize existing knowledge on definitions, key concepts, frameworks, methods and tools, etc., to try to come up with a definition of health intelligence, because as you know, it's used more commonly these days, but it's not always clear what it means. So we conducted a critical interpretive synthesis, which is a variation of a systematic review, just not as strict in the inclusion criteria. So we did a systematic search of Medline, Embase, Google and other references, and searching mainly for the concept of health intelligence. We included 40 records in the sample in the review, and that includes 16 examples of programs that are called titled Health Intelligence. What did we find? Well, the first literature we found was this letter dated back to 1932, but most of the literature came from was published after 2000, with most published in since 2010. So as you can see in this letter published to the editor in the Lancet, that the medical director of the League of Nations is talking about the availability of data for preventative medicine. Okay, so what did we find in general in the data, in the information that we found? Well, we saw various ideas for definitions for surveillance. Very few papers included an explicit definition of what is health intelligence. Most were implicit. Most papers took had a description or definition of health intelligence that is consistent with the term surveillance. And looking at the first dot point, we can see public health surveillance is defined as the ongoing systematic collection, analysis, interpretation, and dissemination of health data for the planning, implementation, and evaluation of public health action. And looking, and below that, I've listed 2 examples of definitions found in the included papers that fit with this idea. So the second one, a central aim of contemporary public health intelligence is the detection of health events as or even before they unfold. And in the following one, which was a commentary on the West Africa Ebola outbreak, it has health intelligence, thus emphasises the concepts, methods, practices and apparatuses assembled to monitor and detect health events. More recently, the movement is toward extending health intelligence beyond surveillance into more contemporary activities such as blogging and data mining social media networks. So as you can see, the definitions are consistent with the idea of health intelligence being surveillance. But more recently, with the use of data mining, data science, artificial intelligence, some variations on the theme have been presented. Another and consistent with the theme of health intelligence with surveillance, is this figure from a 2014 Japanese report, a country report that shows the 8 steps of the data transformation pathway, and the associated text is Figure 3 illustrates the 8 linked steps in the transformation of data into usable health intelligence that are underpinned throughout by information governance in which restricted access to data is managed in a controlled manner. So it's talking about data is the input, analysis as part of the process, and interpretation and intelligence as the output. Similar to that is this figure presented as representing the Global Public Health Intelligence Network and the use of big data. At the top, we see going into the funnel, data, collection of data from various sources where it's processed and analysed, and that information or analysis is titled as intelligence, which is turned into alert notifications. So we're talking about data, processing, and as an output, intelligence. And that's where that's a consistent concept that comes out of the literature. But then there were also definitions that were synonymous with with artificial intelligence, big data, or data mining. And if we look at the second definition, we can see health intelligence uses tools and methods from artificial intelligence and data science to provide better insights, reduce waste and wait time, and increase speed, service efficiencies, level of accuracy and productivity in healthcare and medicine. So again, we're talking about data, but now we're talking about also the use of artificial intelligence and data science. There was also a couple of papers focused on health intelligence from a military or security sense, but focused on outbreak detection and response, as seen here. One definition of intelligence is the obtaining of information, especially of military or political value. And it is this association with military doctrine that has challenged the global public health and humanitarian communities. And then there's also another camp where that talks about health intelligence in an even broader sense than what we would term surveillance. And they use it in a sense that it also includes the concepts of synthesis of research evidence for informed decision making and translation into policy and practice. And this textbook published in the UK by Regmi and Guy is one such example. But even within the textbook, there are some inconsistencies. When you look at the first chapter, often the definitions that they give are consistent with the concept of health intelligence being surveillance. And this is one example of a figure that's consistent with that definition, which talks about data as being inputs, and that's turned into intelligence. But then in later chapters of the book, there's also a focus on methods related to use of research evidence in decision making. So there's chapters on epidemiological studies design, evidence synthesis, etc. And associated with one of those, the chapter on synthesizing public health evidence, they include also, as well as the concept of information or data and information, they include the concept of evidence synthesis, and together those becoming intelligence to inform decisions. So it's not really clear, but it clearly goes beyond surveillance. So at the end of the review process, we didn't really get a clear answer as to what is health intelligence. Looking a little bit further on at another source of information possibly to help us understand the concept of health intelligence are the essential public health functions. And this is the most recent version of the essential public health functions published by WHO in 2024. And again, the answer's not really there. if you look at on the left is a paper by Zhang et al., authors from WHO and regional offices, which was worked towards the essential public health functions, published in 2023, included a box with the 12 public health functions. If you look at the first function in the box on the left, you'll see there's monitoring and evaluating population health status, health service utilisation and surveillance of risk factors and threats to health. And they've given that the short name Public Health Intelligence. But then when the final list was published in 2024, which is in the box on the left, you'll see that they dropped the use of the term Public Health Intelligence, and they've left a definition of the function of public health surveillance and monitoring, but without the short title of public health intelligence. In both boxes, you'll see the second last function in the list is public health research, which is seen as a separate function. Okay, and that's important for this next slide, which is a figure that also comes from the publication of WHO 2024, defining essential public health functions, which shows how the functions can be reorganised by countries in a manner that is consistent with their context. And within this figure, you can see down towards the bottom, again appears the words health intelligence, but this time two functions are included, both public health surveillance and monitoring, as well as the function public health research, evaluation and knowledge. So we're kind of still going backwards and forwards as to what really is health intelligence and getting some agreement. So despite all our advances, there is still a lack of a clear definition and understanding of the concept of health intelligence. One consistent theme that does come across, I think, is the use of information, data and analysis and interpretation of that data to inform decision making, which begs the question, should we just be sticking with the use of the term surveillance instead of, in many of the examples where we're currently using the term health intelligence? So that begs the question, is it time to drop the use of the term health intelligence? Is it just a buzzword used by governments in particular to sound important? Okay, so I don't have an easy answer. I think that's something that I'll leave for you. I think what I'd like to do now is show how the concept of health intelligence, thinking of it as from a surveillance perspective, from the perspective of data, its analysis, interpretation to inform decision making, where does it fit within the concept of evidence-informed decision making? And the figures for this come from these two guides, which I was also had the opportunity to be involved with on the concept of evidence-informed decision making. One published by WHO in 2021 and one by PHONZ. So what is evidence-informed decision making? It emphasises that decisions should be informed by the best available evidence from research, considering factors such as effectiveness, safety, impact on equity, etc. It is a systematic and transparent approach that can be applied across the decision-making process, including to identify a high-priority issue, select interventions or options, appraise implementation considerations, and monitor implementation and evaluate impact. So where does data and its analysis and interpretation fit in those in that process or those steps in decision making. Mostly in steps 1, identifying a high priority issue, and 4, monitoring implementation and evaluating impact. Now, what's the kind of research, where does data and the concept of surveillance fit within the evidence funnel, which is a tool that we use to understand the kinds of research that are input into evidence-informed decision-making, with at the bottom primary research or evidence inquiry, at the second level where we have secondary research or evidence synthesis, where we include systematic reviews, also include burden of disease study and modelling, which is because it synthesises data from primary research. And to then the third tertiary level, where we have evidence products, which can be informed by both evidence synthesis and evidence inquiry. So where does surveillance fit? So if you look at the bottom evidence inquiry, we have already included in the funnel, evidence funnel, public health surveillance, national surveys, routine data, which are all come from health intelligence thinking of it in a surveillance concept. Also could be added to that the concepts of big data, health information and data analytics that were highlighted in the synthesis that we did. And those feed up into evidence syntheses, also inform other secondary research and then evidence products. So that's one view of where health intelligence or surveillance, if we mean it, surveillance fits within the evidence concept of evidence-informed decision making. So I think what do we conclude from all this? Sometimes terms, use of fancy terms are a barrier to collaboration. Collaboration is really needed if we're going to really move towards evidence-informed decision-making. And I think we can all agree, whatever our interests or our passions, I think I would bet that everybody in this room or in this conference today is interested in better use of evidence to inform decision-making for policy and practice. And rather than trying to have words that divide, maybe we should be concentrating more on how we can come together, because it's really the different groups. Really, the best effort is by the different groups working together, finding synergies that we're really going to move towards evidence-informed decision-making. And here we can see in the figure the different groups conceptualised as part of the Guide for Evidence-Informed Decision-Making, and you can see at the top left the groups of data analytics and monitoring and evaluation, where data in particular is important. So I'll finish there, but very happy to take questions. And you're also very welcome to send me questions by email if there's not a chance in the conference or you're just interested in following up. Thank you very much for your time.
Thank you very much, Michelle. That was really interesting, and I'm sure there's going to be a couple of questions. And I know that the definition of intelligence is a hot topic of Barry's, and I see he's going to ask you a question.
Thanks very much, Michelle. Exactly what we were hoping you would tell us. So certainly from a New Zealand perspective, intelligence is one of those words, every time there's a restructuring, if you like, the word intelligence gets pulled in, and over the years, I think it's almost like a shop front. You know, you become intelligence and nothing's much changed. It's a name and it sounds good. When we were setting up PHONZ, one of the things that I did, because I'm part of LinkedIn like a lot of people, I thought I'd actually build a network by seeing if I could, how many health intelligence people I could actually get. And it's really interesting that it's public health intelligence is actually a word associated very clearly in the UK. And if you do a search through LinkedIn for people called public health intelligence, you get very few in New Zealand, not many in Australia, hardly anyone in North America, and a mass of them in the UK. And Chris, who's on our committee, has said that, well, they use that term quite freely. So, yeah, it's a term that's bandied around without actually a clear definition. So thank you for that.
Yeah, could I just add to that? I worked for 10 years for the Victorian State Government Department of Health. When I first started, our section, the area that I worked in, was called Health Outcome Section. Then we became the Health Surveillance and Evaluation Section. And then as things moved on, it's currently called Health Intelligence Unit. What does it do? It does surveillance, mostly chronic disease surveillance. So as part of that project, I talked to quite a few people, and as I said, I'm still in the dark about what it means. And I think perhaps what we could take from it at least is that don't assume that when you use the term health intelligence, people will know what you mean, and maybe you should define or say what you mean by when you use the term.
Yeah, no, definitely. And I think you hit the nail on the head, Michelle, when you talked about it being a bit of a buzzword. And I think it can be a buzzword in sort of the political arena, but sometimes in the health arena, it actually has a purpose behind it. So I think it's getting quite confused. That's my 2 cents anyway.
But what is the purpose behind it, Tim?
That's it. Yeah, exactly. Such a deep question to ask, Michelle, for a Thursday afternoon. And I liked how you went through and you systematically searched for a definition of intelligence, and you found clearly multiple, different takes on what intelligence is. And I think that's the problem is, there's so many different definitions of health intelligence.
Yeah.
Well, just carrying on from that, one of the things that we've, if you like, the trademarks of health intelligence, the way some of us have done, is actually on the interpretation. It's the so what question. I mean, we've had, and I think COVID demonstrated that we've got lots of technology and tools to analyze data, whether it's AI, whatever. But my view is that it's the interpretation, the so what question actually makes the difference. And I think that's the bit that we actually don't train people. Many people just answer that question. And it's only really that when you get putting into the evidence, making the evidence. So in your position, if somebody asked you, they want your interpretation of it, not a bunch of graphs. And I certainly think that confusion between surveillance and intelligence, I mean, I've always viewed surveillance as a tool of getting to the intelligence, not the same thing.
But if you look at the definition of surveillance, it includes interpretation and the using of that for action. So again, I go back, how is it different? But also I think it's important not to forget data is just one part. Data and analysis is just one part of the information that's needed for decision making. In some senses, use of data is easier than use of, because it helps say what is the problem. Governments like to know what the problem is. But my interest these days is more, well, what's the solution? And here it's not data that's going to give you the answer to that. It's research evidence, and it's good quality, well-designed epidemiological studies synthesized in a systematic review, high-quality systematic review that cannot tell you about interventions. Data alone won't do that.
Yeah, well said. We have a few questions in the chat for you, Michelle. The first one is from Srinivas. A very good presentation. To take the decisions on evidence base, do you think there is a necessary for work for staff during their emergencies or not? If not, why? Do you think health intelligence can get help from the database or dashboards rather than from the workforce?
I think I've partly answered that question. I think the data is important, and we saw during COVID there was a lot of data available. But in terms of what works in terms of prevention, treatment, management, that came from systematic reviews, and there was a separate workforce working on that. And guidelines, the high quality randomized controlled trials were taken, synthesized rapidly in living evidence synthesis, and then living guidelines, which were created, which take into account the size of the problem, the effectiveness, cost effectiveness, harms, etc., in terms of deciding and giving guidance to countries about what medications work. And we particularly saw that in Mexico because at the beginning of the pandemic, ivermectin and hydrochloroquine and antibiotics were used frequently. And it was only later as knowledge became available that it was clear, well, some of those actually do harm and they don't do any benefit. So that's where it's the research evidence and the evidence synthesis that really helps. And I think having seen in terms of workforce, I think often, well, I saw in the Victorian State Government Department of Health, there's a lot of emphasis on data and intelligence and analysis of data, not as much on use of evidence and high quality evaluation. And that's where my interest came. And I think the presentation from Jacob Madden on the CDC is really good. I think for Australia, there really is a necessity to synthesize the data that's available. But what I'd like to see is where's the other part as well in the CDC, and I hope that's included about where are the people that are interpreting the research evidence and coming up with solutions, interventions.
Yep, nice. Another question here for you. So take home message, question mark. Don't focus on the semantics, but look at the bringing together all the different parts to deliver the best health outcomes for everyone.
That's what I agree, definitely. And I understand that we use the term health intelligence, and we're not going to stop using it just because of my presentation. But at least if when you use it, you actually clarify what you mean. I think it will facilitate collaboration between areas, and that's where the greatest gains will be.
Yeah, I totally agree. And it sounds like some people online also agree with you with Dr. Sharon Klitsch also saying, let's all agree, evidence-informed decision-making that improves population outcomes is the best way to embody what many of us have thought about public health intelligence. So, yeah, well said.
Thank you.
That's wonderful. Thank you very much, Michelle, for joining us this evening for you, this afternoon for us. It was absolutely thought-provoking presentation to finish our second day for the PHONZ conference. So thank you very much, Michelle.
A pleasure. Thank you.
We'll, of course, be joining you with more wonderful presentations tomorrow for the last day. And there was a question in the chat about how to access the presentations. These will be made available online on our new shiny PHONZ webpage in a couple of weeks. Do you think, Patrick?
Maybe late next week. Depends how organised I am.
Always organised.
Yes. Is there any final comments from the committee or anyone else?
No. Great show. Well done,
wonderful. Great. Well, I shall finish with karakia, and then we'll close the conference for today. Me karakia tātou, kia whakatā ti tapu, kia wātia a ti ara, kia turu whakatau e, kia turu whakatau e, humi e, hui e, hai. Ka pai. Thanks, everyone.
Good afternoon.